morning, good afternoon, good afternoon, everybody. Thank you so much for being here on time. Please, we would like everyone to settle down so that we can proceed. Thank you so much for being here.
Good morning. Good afternoon, everyone. Please, I want us to please come forward. Please come forward. Good afternoon, everyone. You are all welcome to Iwosan Lagoon Hospital Neurosurgery Symposium. So I want everybody to settle down. We are starting.
Good morning. I can't hear you.
Yeah, good afternoon. Good afternoon. Good afternoon, good morning, good night, good evening, wherever you are. You are welcome to Iwosan Lagoon Hospital's Neurosurgery Symposium. And we are going to have the best of a time today because we have some of the brightest minds in the room today. So I want us to please settle down. We are starting shortly. Can you all hear me? Can you hear me?
Okay, now that we are all settled down, good afternoon, distinguished professors, respected colleagues, honored guests, ladies and gentlemen. I am Dr. Oyesiku Okafo, a critical care medical officer from Iwosan Lagoon Hospitals, Ikoyi. It is an honor and deeply personal privilege to be standing on this podium welcoming you all to this Neurosurgical Symposium. As an alumni of the University of Lagos, University of First Choice and Nation's Pride, and former house officer of the prestigious Lagos University Teaching Hospital, I am so excited seeing so many of my tutors here who made medical school a memorable experience. Today we come together not only to share knowledge and advances in this field, but also to reconnect and learn from one another and strengthen bonds that continue to shape our profession and improve the lives of our patients. We are going to be having 2 panel sessions by our distinguished speakers. Please, if we can, you can see them here. I encourage everyone to engage actively, ask questions, exchange ideas, and enjoy this opportunity.
Can you hear me?
Yes, we can.
Yes.
Okay.
Okay, good morning. But I can see the video, but I can't hear what's being said.
Can you hear us now?
Yes, can you hear us, please?
Now I can hear you.
Oh, great.
All right, you are welcome. Thanks for joining us. I encourage everyone to actively ask questions, exchange ideas, enjoy this opportunity to learn from one another. Thank you all for being here. I wish us a truly inspiring symposium.
Yeah, thank you very much, Dr. Okafo. You are all welcome. We welcome everyone that is here. We welcome the professionals, the specialists. We welcome the physicians that are here. We welcome the healthcare professional and medical trainees. We also welcome those that are our esteemed executives that taking time out on this Saturday O1 birthdays to come and learn. So today we are going to learn. We are going to learn about innovation, collaboration in neurosurgery. And I want us to be open-minded. And as we go into this time of learning, I want us to also participate. I don't want us to sleep on it and say, oh, neurosurgery, we don't know what they are doing. Please, this is a time that we need to get the best of what is happening in our environment. Thank you very much. Without much ado, we are going to be welcoming our MD CEO,
Dr. Olivisi Oyeniran, MD CEO, Iwosan Lagoon Hospitals, Ikoyi.
Please. Sorry, anytime you call anybody up, don't just do like this. Please welcome them. You may not know who MD-CEO is. MD-CEO is MD and CEO of Iwosan Lagoon Hospital, Ikoyi. You are welcome, sir.
Good morning once again. My brief is a very short one, and is to give a welcome address and to open the symposium. So distinguished faculty, colleagues, honored guests, our patients and their families, ladies and gentlemen, good afternoon. So on behalf of the boards of Iwosan Lagoon Hospitals, it is my pleasure to welcome you to this Neurosurgery Symposium. Today brings together an exceptional group of educators, researchers, highly skilled clinicians, united by a common purpose of advancing neurosurgical care through excellence in practice, collaboration, and continuous learning. As neurosurgery continues to evolve, forums like this create opportunities to exchange ideas, share experience, challenge established thinking, and ultimately improve patient care. And we are indeed privileged to have an outstanding faculty with us today. And to start with, I'm honored to acknowledge the presence of Professor Nelson Oyesiku. I heard his voice online a moment ago, whose contributions to neurosurgery, academic medicine, and leadership have earned global recognition. Professor Oyesiku serves on the boards of Iwosan Lagoon Hospitals and Iwosan Healthcare Systems. He is our clinical advisor and is the chairman of the Iwosan Medical Advisory Council. We are indeed grateful, sir, for your leadership, for your encouragement, and for the constant challenge you give to us. And in your words, you keep saying to us that we should build as we fly the plane. That council continues to shape our journey, Prof, and as we build an organization that is committed to clinical excellence. I also extend a very warm welcome to Professor Femi Bankole, who needs no introduction in Lagos and beyond. Professor James Balogun and Dr. Akimbo, who have traveled all the way from Ibadan to join us and bless us with their physical presence. Thank you to you both, sir. Dr. Ahmed Ninolo Ahun, and I hope somebody is going to just tie Dr. Ninolo to that seat so that he can stay. But thank you so much for setting, whose vision and leadership have been instrumental in developing neurosurgical services within our hospitals. And in fact, in bringing today's symposium to life, I remember this symposium started with a 5-minute discussion in my office with Dr. Ojo. And in his usual practice, the answer was yes, and then we got to work. Dr. Ojo, thank you so much for your commitment and for your collaboration, sir. One of the defining features of today's program is that alongside the scientific sessions we are going to have, we will hear directly from patients who have experienced neurological disease and neurosurgical care. That was a deliberate decision. Medicine advances through science, through research and innovation, but is ultimately judged by the life or the lives it changes. It is our patients who remind us of what good clinical outcomes truly mean. Their experiences give meaning to our science, to our innovation, to our brilliance, to our intellect. It is their experiences that give meaning to those elements. And they remind us that every diagnosis belongs to a person, that every procedure affects a family, and every successful operation marks the beginning of a new chapter in their lives. So today, our patients are not simply members of the audience, but they are major contributors to this symposium. And I really want us to pay attention as they share experiences with us, because I believe it's going to enrich the experience today. So their perspective, of course, is going to enrich our discussions, challenge our assumptions, and it's going to remind us that technical excellence and compassionate care are actually inseparable. We are deeply honored that some of them have chosen to share their stories with us today. In many ways, that reflects what Lagoon Hospitals has stood for over the past 40 years. Our greatest milestones have never been in the buildings we open or the technologies we have acquired. We see those as enablers. But our biggest milestones have been in the lives we have touched, the trust we have earned, and the patients who have placed their confidence in us. This symposium is therefore especially meaningful as it forms part of the Lagoon Hospital's 40th anniversary celebrations. For 40, I thought somebody's going to, I didn't say 4 years, 40. Right. Thank you. So for 4 decades, we have had the privilege of caring for generations of Nigerians. While we are proud of that legacy and we celebrate the past, we also take this as an opportunity to recommit ourselves to what lies ahead. That belief is the foundation of our 40th anniversary Thought Leadership series, this being one of them. We believe we have a responsibility not only to deliver excellent care, but also to advance healthcare through education, through research, and the open exchange of knowledge. Today's symposium is an important expression of that commitment. As many of you now know, Lagoon Hospitals is now part of Iwosan Healthcare Systems. And the other entities within the system are Huracare Multi-Specialist Hospital, Piedmont Memorial Hospital, and Iwosan Wellness. And our near future is the PPP partnership we have in the Lagos Medipark Hospital. Together, we are building an integrated healthcare system founded on clinical excellence, innovation, and research. We believe the future of healthcare belongs to institutions that work together, learn continuously, and remain committed to raising the standard of care. And the brain behind all of these things I just spoke about in terms of integration, in terms of building a sustainable ecosystem, is a woman we so much respect and who has walked in at the right time. And I'm taking a risk now because I want to use a brain metaphor in a room full of neurosurgeons, but I'll take the risk anyway. So please join me in welcoming the cerebral cortex of Iwosan Investment Limited, Mrs. Fola Laoye, as she walked into the room. So the program before us reflects both the breadth and the future of modern neurosurgery, from pituitary disease to neuroendoscopy to skull-based surgery, neuro-oncology, spine surgery, and cerebrovascular care. More importantly, it reflects our shared commitment to achieving better outcomes for every patient who trusts us with their care. So to our faculty, thank you for your generosity, thank you for your time, thank you for your commitment, thank you for your service. Thank you for giving yourself to the service of humanity. And to everyone participating today, thank you for your commitment to learning. Dr. Lee didn't mention today is an Owambede, but yet we have decided to come today to share. So thank you. It is now my distinct honor and privilege to officially welcome you to the Iwosan Lagoon Hospitals Neurosurgery Symposium of 2026 in collaboration with Lagos Neurosurgery Educational Forum. I wish you a productive, engaging, and rewarding afternoon. Thank you very much.
Thank you very much, sir. Please, a round of applause for Dr. Yeningo. Thank you very much. You're all welcome. Thank you for the presentation, Dr. Yeningo. We are going to the next on our agenda. I'm going to be calling on Dr. Ojo Omotayo, but before he comes in, I have a personal testimony about Dr. Ojo Omotayo. Of course, he trained me. I was part of, when we were in medical school, I was in 400 level, and we went for this normal posting, 400 level posting, and you know, something you need to also know about neurosurgery or neurosurgery team is that they are very disciplined, they are dedicated, they are consistent. When you're looking for people that are very disciplined, consistent, and they are very hardworking, you always find it among that team, neurosurgery team. It's always like that. If the timing that we are going to start our round is 6 o'clock a.m., you are going to meet all of them 6 o'clock a.m. It dare not medical students come in by 6:01. So they were in theater that day. And because of that, you know, hall for neurosurgeon team, we couldn't come near them. And it just beckoned on me. Medical student, come. Have you seen spine before? I said, no, I've not seen spine before. He showed me. That was the first time in my life I would see our spinal cord. And up till now, I can't just forget how our spinal cord actually looked like. I said normal anatomy. So Dr. Ojo, I want to call him for overview, but before that, I just want to know that one of the most humble person I actually met in medical school and among colleagues, Dr. Ojo. Imagine a consultant beckoning on you. You know, if you just, hello, hi, it's not common. Please help me welcome Dr. Ojo as he come to take the overview. It's a privilege to have learned under him. Well done, sir.
Thank you very much. So it's afternoon now. Good afternoon, everyone. Particularly good afternoon, Mrs. Folala Oyefo, and also for coming around to see what we do. Your effort is well appreciated. So I have a speech, so I will go through it. Distinguished faculty, invited guests, esteemed colleagues, fellows, residents, other medical practitioners, and students, of course, ladies and gentlemen. It is with immense pleasure and a profound sense of gratitude that I welcome you all to this Neurosurgery Symposium, jointly organized by Lagoon Hospital and Lagos Neurosurgery Educational Forum. About 8 years ago, myself, Professor Bankole Inlud, we decided to see how we can push the frontier of neurosurgery. We acknowledge the limitations on ground vis-a-vis no cadaveric trainings, limited options and opportunities. And we came together and formed the Lagos Neurosurgery Educational Forum. And what we do is every year we gather together and organize a detailed workshop which will include didactic lectures as well as cadaveric practices. I must say that this experience, this workshop had been a major factor in encouraging and improving the expertise that is available locally. And last year, Lagoon agreed to work with us more than before and practically support us fully. Thank you, Dr. Yenirom. And that is why we are here today. So, today is much more than another scientific meeting. It is an opportunity to reflect on the practice of neurosurgery in Nigeria for over the past 2 decades. It is also an opportunity to look ahead with confidence, purpose, and renewed determination. 20 years ago, many conditions that are now routinely managed within our borders were either considered beyond our capacity or required patients to seek treatment abroad. Access to advanced imaging was limited 20 years ago. Microsurgical techniques were still evolving locally. Complex skull-based surgeries, cerebrovascular surgery, minimally invasive spine surgery, neuronavigation, intraoperative neurophysiological monitoring, modern neurocritical care, advanced neuroendoscopy, and multidisciplinary management of complex neurological disorders were not readily available. Today, the story is remarkably different. Across our country, neurosurgeons are performing increasingly sophisticated procedures with outcomes that compare favorably with international standards. Modern operating microscopes, I must say the best microscope in Nigeria, probably in West Africa, is the one in Lagoon. And if I put it in perspective, it's like driving a Rolls Royce. All right. More importantly, our greatest resource remains the highly trained Nigerian neurosurgeons, anesthetists, intensivists, nurses, and allied professionals whose commitment continues to redefine what can be achieved for our patients. These advances represent more than the technological progress. They signify hope for patients, confidence in our healthcare system, and a growing capacity to deliver world-class neurosurgical care here at home. Our responsibility, however, does not end with celebrating these achievements. We must continue to build stronger institutions, embrace innovation, invest in research, train future leaders, and ensure that every advancement ultimately translates into better outcomes for our patients. To my fellow consultants and colleagues, I encourage us to continue pushing the frontier of neurosurgery. Incidentally, aside Professor Oyesiku and Dr. Ninolo, every other faculty have been at Lagos Neurosurgery Educational Forum to talk and to demonstrate. So I encourage us all to continue pushing the frontiers of neurosurgery. Let us challenge existing boundaries, pursue excellence relentlessly, contribute to scientific discovery, and mentor the next generation with generosity and purpose. The future of neurosurgery in our country will depend on the standards we set today. To the residents and trainees, you represent the future of this specialty. Pursue excellence without compromise. Develop technical masteries, sound clinical judgment, unwavering professionalism, and genuine compassion. I would say, get the skill by all means possible, because you never know who the next patient will be. Never become satisfied with mediocrity. The privilege of operating on the human brain and spine demands nothing less than your very best. To our colleagues in other specialties and referring physicians, I hope today's symposium will reinforce one important message. Modern neurosurgery in Nigeria has evolved tremendously. Many conditions that previously required treatment overseas can now be managed successfully within our healthcare system, both open surgery, intervention cases, and so many other things that were impossible before. We also note that early diagnosis, timely referral, and close multidisciplinary collaboration remains essential to achieving the best outcomes for our patients. This symposium has been carefully designed to provide practical insight into contemporary neurosurgery practice, the length and breadth of neurosurgery. We have deliberately assembled a distinguished faculty comprising leaders in their respective fields. Each speaker has been thoughtfully selected because of their expertise, experience, and significant contributions to the topics they will present. I have no doubt that the discussion will be intellectually stimulating, clinically relevant, and beneficial to every participant. As we exchange ideas today, may we strengthen professional relationships, inspire innovation, and reaffirm our collective commitments to advancing neurosurgical care in Nigeria and across Africa. It is my great honor and privilege to welcome you all. Thank you.
Thank you so much, Dr. Motayo Ujo, for that amazing speech. I feel like I gained a few more IQ points just listening to that. Thank you so much for demystifying, for letting us know the history, how neurosurgery started, and where we are right now. Thank you for giving kudos to Iwosan Lagoon Hospital and our microscope. That was lovely to hear. I've come up here to do two things. I would like to welcome our colleagues and guests that are joining us online. Thank you so much for being here with us. I would also love to recognize Dr. Kuyoro, MD, Iwosan Lagoon Hospitals, Ligali Branch. One of our partners is also here, Dr. Ife Ricketts, Director of Nigerian Shepherds Council. Thank you so much, Ma, for being here. All right. It's time to get into the speakers. It's time to learn so much from our distinguished speakers and panelists who are here today. I would like to introduce to us Professor Nelson Oyesiku, distinguished professor, and is going to be one of our panelists and speakers today. Please, can we pull up his citation? Professor Nelson Oyesiku is the Van L. Weatherspoon Jr. Eminent Distinguished Professor and Chair, Department of Neurosurgery, and Professor of Medicine and Endocrinology at the University of North Carolina, Chapel Hill, USA. He has held notable positions in various prestigious capacities, including member of the Board of Directors of the American Board of Neurological Surgery, Chairman of the Maintenance of Certification Committee, Chairman of the American Board of Neurological Surgery, member of the Board of Governors of the American College of Surgeons, and the Advisory Council for Neurosurgery of the American College of Surgeons. He is one of the first to use 3D endoscopy in pituitary surgery and is also one of the few surgeons in the world to utilize advanced 3D endoscopic surgery for the resection of pituitary tumors. He was also a member of the Residency Review Committee of Neurosurgery of the ACGME and a fellow of the American College of Surgeons. He has held leadership positions in the following organizations: the Congress of Neurological Surgeons, the American Academy of Neurological Surgery, the Georgia Neurosurgical Society, the Society of University Neurosurgeons, and the World Federation of Neurological Societies. He is also a partner with us here at Iwosan Lagoon Hospitals. Unfortunately, he's not physically present, but he has joined us online. You're welcome, sir. Thank you.
Good morning, good afternoon.
We can. Yes, we can.
Excellent. Is very apropos.
Please start sharing, sir. You're not sharing yet. We can see you, but not your slides.
Okay, let me see here because I may have to switch. Let me see. Slides to Dr. Ujo. I thought they were up already.
Please share now. You can share now, sir. You can go ahead.
Are the slides on the podium in the auditorium?
You can share now. I think we've made you a co-host. You can share now. I have the slides. We have your slides, sir. We'll share from our end.
Okay, why don't you share?
Please give us a minute.
I thought that was what was going to happen. I apologize.
It's up now. Can you see?
Okay, so yes, I can see. Okay, what slide are you on? The disclosure slide?
Yes.
Slide number 2.
Disclosures, yes.
Okay, very good. So I have no disclosures to volunteer. Next slide, please. Okay. So the Center of Excellence concept was first introduced in the United States in 1994, starting with the Heart Bypass Center project under Medicare. Basically, the concept is that a Center of Excellence involves the assembly of a cohesive team of specialists who all promote collaboration and apply best practices around a specific focus area of clinical medicine with a view to improve results and patient overall outcomes. Particular to pituitary tumors is the multidisciplinary approach involves obviously neurosurgery, usually in a dyad with endocrinology, supported by other specialists such as MT surgeon, otolaryngologist, radiation oncologist, neuropathologist, and neuro-ophthalmologist and radiologist. In general, that is supporting a system where there are fellows and residents also engaged in education, training, and research. And also, from the standpoint of patients, is to provide patient education and support as they go through the pathways of care. Next slide, please. So, in 2012, this article was published. It was a joint article by 5 authors, myself being one of them, where we described the concept of pituitary centers of excellence. And you can see the reference there. I don't see whether or not it's up there, but you should be able to see the reference for that article. It was published in 2012 in Neurosurgery.
Yes, we can see it.
Yes. So that next slide, please. So if you look at this algorithm to the right of the slide deck, where you see the pituitary PTCOE, basically that stands for pituitary centers of excellence. And you can see that the dyad that leads that pituitary center of excellence is the endocrinologist and the neurosurgeon collaborating to lead the team with supporting units. After our paper was published in 2012, the concept was then advanced by the endocrine society, specifically the pituitary society, in this publication that you see here. And the view was to gather enough support in the healthcare domain to promote this concept. And that has since advanced, and it's very likely that this will become generalized within the next year. Next slide, please. So what's the rationale for the Pituitary Center of Excellence? It certainly was not originally in pituitary surgery. It was had been applied in medicine and had already been in the domain of pituitary disorders. And if you do a Pituitary Center of Excellence search on Google, you'll get over 500,000 results. So it's by no means a strange concept. Next slide, please. This slide shows the high prevalence and impact of pituitary tumors. And from an epidemiological and a public health standpoint, this is the justification. These tumors occur at about a frequency of 1 in 6 or 1 in 5. So if everyone in that room got an MRI, on average about 15 to 16% may have an undiscovered or unrecognized pituitary adenoma. May not be symptomatic, may not never be needed to be removed, but it's there on imaging. And when patients have MRI scans for various and sundry unrelated symptoms, like headaches, for example, these are discovered. So you can see that there have been several papers published over the years that speak to the incidence of pituitary tumors. And this warrants the innovation and the availability of centers of excellence. Next slide, please. Okay, so just a few general points of information in this list. Pituitary tumors are virtually always benign tumors. There's a small number, about maybe 1 in 1,000, 0.1% that may be aggressive malignant tumors. They are basically divided into 2 groups, those that are hyperfunctional, in other words, are associated with excessive hormone expression, and those that are not, and that usually present with problems with mass effect. In general, patients are otherwise healthy. They have normal expectations of life. It doesn't usually result in significant curtailment of mortality or anything like that. And so because of that, patients have a high expectation for return to full function. Furthermore, there are other modalities for treatment, such as medical or radiosurgical options. And so this raises the bar substantially on the expectations from surgery. Results must be very good because, again, as I said, the patients, other than the fact that they have this tumor, otherwise expect a full return to normal activities of living. More recently, over the last decade and a half, there have been advances in surgery, particularly in endoscopic surgery, that has altered the landscape of offerings. When I trained, virtually all the surgeries were done with the microscope, and that has substantially altered with the introduction of the endoscope. There have been advances in radiosurgery, gamma knife treatment, LINAC accelerators, and so on for circumscribed tumors that have extended from the confines of the cella. Endocrinology-wise, there have been new medications in the last few years that have really impacted the care of these patients, particularly in Cushing's disease and in acromegaly. We're doing better with imaging, 3D imaging in particular, and the outcomes and the experience of transnodal surgery has improved dramatically with training and so on. Next slide, please. So this slide shows the mortality and complications as a function of hospital and surgery. And this slide is very important because it speaks to the craniotomies and transcranial surgeries and so forth are done in several institutions across the country. But if you look at the conclusions in the last sentence, that the practice with transcranial surgery is less well represented than craniotomy for other forms of tumors, and tends to be clustered at very few very few active centers. So compared with craniotomies, which are more disseminated. And the conclusion of the authors was that the implications for neurosurgical education are very significant. So if a fellow or a resident trains at an institution that has a low volume, it means that their ability to gain the relevant experience is less so, or more limited. And this is from the group of physicians at the University of Virginia. Next slide, please. So the examples that I would give in terms of centers of excellence that you can look up, for example, the Society of Bariatric Surgery, under the aegis of the American College, was one of the first that launched centers of excellence programs. Another is the trauma center designation, and then another is stroke centers. And all of these are just examples of how this has been done in various areas of medicine as well. Next slide, please. Women's health has also received attention, and so there's a National Center of Excellence policy that was established in 1996 on women's health. Next slide, please. So what is the mission of a pituitary center of excellence? One is to develop a comprehensive slate of care and support for patients with pituitary tumors. In other words, one-stop shopping. When the patient arrives at the pituitary center of excellence, everything that needs to be there is there. All the specialists, all the equipment, all the protocols, and so forth. Secondly, it's very important that the center of excellence participate and is prominent in the training and continuing education of pituitary disease medicine and surgery for physicians. Thirdly, there should be some research ongoing, whether it's clinical, translational, or basic, usually clinical and translational in this domain. And then finally, exemplary outcomes, quality metrics, and patient satisfaction must be top of the line. So these are four key aspects of it. Next slide, please. And so just to expand on that concept, the mission, first providing superior patient care. What does that entail? First of all, the institutional commitment to excellence, and you heard from Dr. Oyenola earlier on about the commitment to excellence at the Iwosan Lagoon Hospitals and healthcare system. A designated medical director is key. I talked about a dyad between the endocrinologist and the neurosurgeon. And then we talked about the need for sufficient experience and volumes because that impacts outcomes. So the track record of the neurosurgeon and the endocrinologist is key. The collaboration with the other participants of multi-specialties, I won't go into all that detail, we talked about that already. Having the requisite instrumentation and equipment for endonasal skull-based surgery. Could you advance the slide, please? One forward. Yeah, perfect. Thank you. The use of clinical pathways and standard operating procedures is key, and that is very important because nursing care, allied health, and so forth must also be on the same page. We talked about the provision of education and training programs, residents, fellows, as well as nursing and allied healthcare, and then the presence of research in some capacity, clinical and translational. Next slide, please. So basic requirements for the excellence of the neurosurgeon obviously goes without saying that such an individual must have undergone
Please, a round of applause. Thank you very much, Prof. Thank you for that awesome, breathtaking presentation. I'm going to be going to the next. Hope you're enjoying ourselves. I can't feel the energy. Hope we're enjoying ourselves. Thank you very much. I'm going to be introducing the next speaker, but before that, I want to recognize the presence of Dr. Oluyemisi Odubajo, the MD of Iwosan Lagoon Hospital, Ikeja. You're welcome, sir. And also Dr. Oluwatomi Kogo, the MD, Iwosan Lagoon Wellness. And our special advisor, Dr. Haluko. You're really welcome, ma'am. It's nice to have you. And please, if I do not recognize you, don't be angry. I will still introduce you. Okay, so I'm going to be calling on Professor Femi Bankole, but before that, let me just talk about his profile. He's going to be talking to us about interventricular neuroendoscopy, prospects, intraventricular neuroendoscopy, prospects and limitation. Can you help me put up his profile while I... DJ. Thank you. So, Professor Femi Bankole finished from the Medical School of Obafemi Awolowo University, Ile-Ife. I spent 2 years in that place, and I was like, wow. So for somebody to finish there, it's not beans. So he finished from OAU, Ile-Ife, and he didn't just finish, it was also on the dean's list. People that don't understand, that is the highest academic achievement to have. 2 years in Obafemi Awolowo University, boy, I have to come back. I left and I came to Lagos. So, after internship and national service, he pursued his desire for specialist training in neurosurgery. And you know that this is a motivated person at Lagos University Educational Hospital, Luth. So when you hear Ile-Ife, you also hear Luth, because there's something about excellence with that in that space. Professor Bankole completed his residency in 2002, and he was awarded the Fellow of West Africa College of Surgeons. And after receiving his fellowship, he had further specialty training at various hospitals, including the Hemorrhage Clinic, Atlanta, Georgia, the Mayo Clinic, Rochester, Minnesota, and the CURE Cure Hospital, Mbale, Uganda. As a consultant neurosurgeon, Professor Bankole has championed access to quality neurosurgery care nationally and across the sub-region. His stated objective is to further develop the practice of neurosurgery in Nigeria with special regard to improving the quality of and access to neurosurgical services throughout the country. This commitment has resulted in the training of specialist manpower who has worked in many states across the nation and abroad. Since 2003, he has worked at Lagos University Teaching Hospital, Idiaraba, Lagos, Luth, as consultant neurosurgeon, and his passion has been increased to increase the scale and level of neurosurgical practice, not only in Luth, but across Nigeria. Professor Bankole also holds on academic appointments in Department of Surgery, College of Medicine, University of Lagos, where is the professor and
time has to be suspect. Good afternoon, everyone. Thank you, co-moderator, for that rather long introduction. Well, let me just start by thanking the organizers for inviting me. Iwosan Lagoon Hospital Systems, getting bigger soon. Thank you very much for that. As Dr. Ojo mentioned, I'm part of the Lagos Neurosurgery Educational Forum already. It's a privilege to be here. Professor Oyesiku, one of the lines said that I was at Mayo Clinic, not Mayo, Emory Clinic. So Professor Oyesiku is my very senior organ. He taught me everything that I know about pituitary surgery way back then. And because I didn't learn as much as I should, I went back again. So it's a privilege to be on the same panel with him as well. And I must say that he's been someone that has held our hands in trying to do all that we do. He has given of his time, his expertise, and of his connections as well over the years. He's been to Luth. He's worked with us at the Nigerian Academy of Neurological Surgeons. So, Prof, I know you're listening, so thank you very much. We really do appreciate you.
Many thanks, Kevin.
So, my topic is intraventricular neuroendoscopy prospects and limitations. In preparing for this, does this work? Yeah. All right. Who do I point to? Okay, cool. All right. All right. So I'm going to try and keep to 20 minutes as much as possible. Of course, the introduction, I work at the Lagos University Teaching Hospital and the College of Medicine, University of Lagos, so we'll skip that. I do have a disclosure. It's not a financial disclosure, but it will come in the course of the presentation. So I just want to say that I'm one of the mentors of NeuroKids. I will mention what NeuroKids is and what they do slightly later on, but just so that you know that I'm not uninvolved. So talking about intraventricular neuroendoscopy, why that? Well, Dr. Joe, I think, was the one that just handed out the topics, and he must have seen something in my eyes that made him choose this. But neuroendoscopy is a very wide and vast field, so I'm going to limit the presentation more to its application as far as hydrocephalus and the treatment of patients with hydrocephalus is concerned. So how did we get here? Well, as far back as 460 BC, Hippocrates was the first one to look into body cavities, and endoscopy literally means to look inside. And anywhere you see endoscopy, it just means looking inside. And so we move forward a little bit, and over 100 years ago, people have started looking inside the brain. As far back as 1910, Lespina's was a very courageous urologist who used a cystoscope to look inside the brain and attempt to burn the choroid plexus. We will not talk about outcomes just yet. But Walter Dandy advanced that. He was a neurosurgeon, one of the trainees of Harvey Cushing, and then he used a handheld speculum to visualize the choroid plexus and try and remove it. Again, we won't talk too much about the outcomes just yet. And he was also the first person to coin the term ventriculoscope, and also the first person to go on to perform the first open third ventriculostomy way back in 1922. Endoscopic third ventriculostomy was done by Mixter for aqueductal stenosis in 1923, and then by the 30s, Putnam had developed a technique for choroid plexus coagulation using the endoscope. And then by 1935, Scarf developed an angled lens system and used unipolar cautery and an irrigation system to improve on the procedure. What stands out from all of these earlier attempts were that the instruments were quite crude. The optics were poor. Illumination was poor, at least when we compare to what we have now. And hence the results were also poor. The outcomes were less than 25% survival, talk of intellectual potential. Fortunately, as human beings, we continue to work hard and improve on our failures. By the 50s, Harold Hopkins had developed the solid rod lens, which we now all consider as the norm. And then flexible fiber optic lenses were developed in the 70s by Fukushima in 1973. A gentleman called Griffith continued to treat patients with choroid plexus cauterization through the 70s and the 90s. He was based in the UK. He was the only one basically doing it. He only had a limited number, but he persisted because he felt that that was a useful way of treating this condition, hydrocephalus, which I will talk a little bit about. So currently, the resurgent interest in neuroendoscopy has evolved over the last 20 or so years and has been driven basically because the optics are now much better. The illumination is better. The endoscopes are smaller, so the instruments, equipment are not as crude. They're not as large and as invasive as they used to be. And also because we now realize that there's a lot of benefit from minimal access surgery to achieve the maximum impact. So that's one of the drivers for endoscopy anywhere, and especially in neurosurgery. Again, I wasn't sure what the audience mix was going to be like. You know, sometimes you don't want to talk. If you know how neurosurgeons can be. If you are talking too basic, they'll just say, "You don't. What's wrong with this man?" But if you now have non-neurosurgeons and you start talking at a certain level, they'll say, "You know, this person is just trying to." So please, just somebody should wave if you think I'm going. Anyway, but we have different types of endoscopes. So this is just like type of endoscopes. They're the solid rod lens developed by Hopkins. They're very good. The resolution is very good. The operative field is well illuminated, and there are a lot of instruments that have been developed to help achieve a lot of procedures using this device. The disadvantages is that one of these advantages are that you have to fix the endoscope or somebody has to hold it, but obviously fixing it is better. And because of the number of instruments, then the scope tends to be a bit larger. Then there's an attempt to bridge that gap by the semi-rigid rod, which is slightly smaller, but because it moves around, then people can get easily disoriented. And then you come to my own favorite tool, which is a flexible neuroendoscope. Its advantage is that it's very mobile and gives you a wide operative field. You can actually see 360 in any direction. The problem is that the lighting, at least until very recently, people like Professor Oyesiku have access to 3D and maybe 4D endoscopes, but with the flexible endoscope, sometimes the operative field is not as bright and the imaging quality is slightly less good as that of the rigid scope. And they have issues, there are issues with sterilization, especially with things like Creutzfeldt-Jakob disease, which is why in the UK and I think in the EU, they do not like to use flexible endoscopes so much. Let me move on. So with the endoscope, it helps you to look inside. But when you've looked inside, then you must be able to do something when you've looked inside. Otherwise, you'll see a lot, but you won't be able to do a lot. So there are a lot of instrumentation that go along with endoscopy, diathermy, which both monopolar and bipolar. You have grasping forceps. Some of them I have tried to just show different things here. You have the scissors, a grasper, biopsy forceps. So there are different things that come in and can be used. With the larger rigid scopes, you have the full complement of the adjuncts. But with the flexible scope, you have limited adjuncts. So that also limits a bit what you can do. But it's eminently useful for treating patients with hydrocephalus, balloon catheters, and other things like that. All right. One of the beautiful things about endoscopy is that the anatomy is excellent. So my co-moderator, one of these days when you come around, we'll be able to show you inside the brain as well. But the anatomy is excellent, and when you come in, and that's one of the things that really sold people like me to endoscopy. So when you look in, so this is a picture inside the brain, and you can see that the quality of the image is very good. This is choroid plexus. This is the foramen of Monroe that we heard about when we were in medical school. That is the thalamostride vein, and this is septal vein. Anyway, so this is a picture you see when you're looking into the lateral ventricle using a rigid scope. And what you want to do is, and then you also see this. So this is the floor of the third ventricle. We use 9 o'clock to 3 o'clock. So this white band here is the optic chiasm. I don't know if you can see the pointer. And then the reddish blush here, that's the pituitary gland that Professor Oyesiku just talked about. That's the pituitary gland. You can actually see a very good view of it. If you have good eyesight, this part at the back here that is pale is what is called the neurohypophysis. That's the posterior pituitary gland. Anyway, whatever. And then this is the floor of the third ventricle where we would make an opening. These are mammillary bodies. So you see all of this. These are not things that are talked about. These are things that you will actually see. This is a mammillary body on either side. And if you go further backward, you see this opening here, which is where the aqueduct of Sylvius is, and where fluid CSF is supposed to go from the lateral ventricle into the fourth ventricle. And all of this you will see. Now, I'm going to show you another slide, but just keep an eye out on this quality of imaging. Now, the quality of imaging here is a bit less, but you can still see. So the first few images were from a rigid scope. This is from a flexible scope. And that's because with the flexible scope, first of all, you can see the aqueduct clearly, but what you're seeing here is actually the roof of the third ventricle. So you're going and you're flexing backwards. So you're almost looking behind. You can look around corners. You can do a lot of stuff with it. But so you lose a little bit of image quality, but you still get to see a lot more. So just something on endoscopic ventricular anatomy. All right. So why is it important? Hydrocephalus is bread and butter. It's what we teach the medical students. But every neurosurgeon that is here and has ever treated a child with hydrocephalus will understand that as simple as treatment is, it's also a big pain. So again, for the benefit of everybody, it's a hydrodynamic disorder that leads to the accumulation of cerebrospinal fluid within the ventricles and subarachnoid spaces. In children, it can be incapacitating. In adults, it can be deadly. Now, the problem with hydrocephalus is that there are quite a lot of it that goes around. An estimated 100,000 to 250,000 cases every year, new cases, in Africa alone. However, the treatment is compounded by poorly developed healthcare systems, which we have, and then the poor referral and follow-up care. What does it look like? In infants, patients are usually irritable, they can be drowsy, obviously the head is enlarged, the frontal is tense, and they have the classic sun-setting eye appearance. In older children, the head doesn't get to be that large, but it can still enlarge. But then they have headaches. Older children and adults, one of the things to look out for is decreased school performance. So decreased school performance is an early indicator of raised intracranial pressure, obviously, and then sometimes patients develop double vision because they have lateral rectus palsy. And when you examine them, you find hyperreflexia and clonus. All right, so moving on. The problem with hydrocephalus is that you've set very high goals for yourself. You said that your goals of treatment are you want to optimize neurologic function, and you also want to achieve good cosmetic result, because if your head is too big, you may run the risk of being called headmaster when you're in primary school, and all sorts of things like that. So those goals are quite lofty, but the problem is, how do you achieve them? So for over the last 6-7 decades, shunts, ventriculoperitoneal shunts, have been the mainstay of treatment. And the question is that if they are working, then why do you need to change a winning team? Well, the problem is that shunts fail. Shunts fail. They fail quite often, actually. And they account for about 30% of the workload in most neurosurgical centers. And about a quarter of shunts fail very early on. Within the first 3 to 6 months, many of the shunts have failed. And as a result, many patients die because they get shunt infection, or they have worsening neurology because of that. So that's why we cannot just rest on doing shunts alone. We do shunts and we do it well, but we know that it has its limitations. And so it became time again to think a bit differently and say, what can we do differently? So when I was going through the history of how we got here, I mentioned endoscopic third ventriculostomy. It had been tried many years ago. So it's a bit of old wine in new wineskin. And what we now found over the last 20, 25 years is that when you combine ETV with choroid plexus cauterization, then it increases the scale and the scope of patients that can be treated successfully with hydrocephalus. ETV on its own will bypass the area of obstruction, and while the choroid plexus cauterization will reduce the burden of cerebrospinal fluid that needs to be absorbed. There are some other mechanisms by which they work, but I will leave it at that for now. So how has that impacted how we treat hydrocephalus at the Lagos University Teaching Center, Lagos University Teaching Hospital? So this graph is about 20 years old. It's data from about 20 years ago when we first started doing endoscopic third ventriculostomy. And so the red line represents shunts, and the blue line were endoscopic procedures. So we started from 0 here, and over about 8 years, we were here. So basically, we saw a decline in the amount of shunts that we were doing. It dropped dramatically, and then it rose again, and then dropped here. That was up until 2013, thereabout. However, things have not remained the same. So here is the last 6 or so years, and we see that we are still back to shunting a lot. And our ETV rates have reduced again. Now, there are some reasons for that. One of the reasons is that at this point in time, we're able to get dedicated theater time and have time to just treat patients with hydrocephalus. But for the reasons that we will not say too much about, some of it bordering on manpower shortage, otherwise known as, we've had to cut down on that. And so now we're having to do a lot of the shunts or children as emergencies and by force treat them with shunts. And that, unfortunately, has even affected our own outcomes more than we would have liked it to. Anyway, so I'm going to blitz through this because most of the people here are not neurosurgeons and they are not planning to start an ETV program anytime soon. But just in case you do that, there are some steps you want to go through. You want to acquire the skill. By all means, like Tyra said, acquire the skill. Then acquire the equipment that you're going to need. Minimal access. The surgery of the 21st century requires investment in equipment. So I'm saying that also because I know that there are a lot of stakeholders and powerful people here beyond us surgeons. So please, I would like to encourage you that if you want good outcomes in neurosurgery, then you must invest in equipment. You must invest in equipment. And I want to, at the same time, congratulate and celebrate Iwosan Lagoon because they have done that in time past. And I'm sure they are set to do much more. All right. And then you have to train your staff. You definitely have to train your staff and equipment care. I'll just go on. So I went here in 2006, so that's 21 years now. No, 20 years ago. Yeah. The Kio Hospital is in Uganda. It is actually a center of excellence, a world-class center for treating children with hydrocephalus. And the gentleman here, Professor Ben Wolf, was the one that taught me, along with this other gentleman here. And this was me back in 2015. Again, I don't always get it the first time, so I have to go back again at the hospital. It's a very wonderful place to be. But wherever you need to get to go, please go. Just make sure you get the skills. The equipment is available. I mentioned NeuroKit. So NeuroKit is a charity organization actually set up by Professor Wolf and dedicated towards trying to teach the skills of ETV CPC and also help people in getting the equipment that they may need to be able to perform that. So that's why they are there. And Carl Stotz is there because they are the ones, as far as I know, at least within the Western Hemisphere, that provide the flexible neuroendoscope. I think there are some people in Japan that may be doing that as well, but I'm not sure. for the flexible neuroendoscope. It can be expensive, but at the end of the day, it will be cost effective, and it is worth it. Equipment maintenance and staff training. So I don't know how well this is clear. So can you see these dots? So this is an aqueduct that is closed congenitally. Each of those dots represents, I tell my residents, that represents each resident through whom their hands have passed on the neuroendoscope, because in handling it, they bend it, and then they break one or two fibers, it shows up as a black dot. And so the way you know how, the more black dots, you can see the black dots, the more residents that have been there. So the fibroscope is very fragile. If you bend it too much, it won't break on the outside, but the fibers inside will break, and then your image quality will degrade. The rigid scope, on the other hand, is sturdier, but can also break. I think I learned this lesson very early on, because when we got to Mbale, Dr. Mugamba, who was on the left, he was like 2 months my senior, and they had just gotten brand new rigid scopes, and he wasn't used to rigid scopes, he was used to flexible scopes. And you know, flexible scopes, you can do this. So he just, and this is a 2 millimeter, 3 millimeter scope. He just did it, and that was the end of that. And I was brand new. That was the first time it was coming out. You know, so I learned very early on that you must train your staff, otherwise you're going to run out of things. So that's very important. What are the prospects? So I have run out of time. Prospects, non-aqueductal stenosis. I believe that no child with aqueductal stenosis needs to have a shunt, or at least should have a shunt as a first treatment. ETV will work in 80 to 90% of cases with these children, ETV CPC. And in fact, this is the poster child for this procedure. Going on, even some patients that have tumors. So these are some of our patients that in time past have had tumors. This patient had a medulloblastoma. All we did was an ETV, and the child was able to get better until we could go back and remove the tumor. This is another patient that had a medulloblastoma. Different things. This particular patient, if I have time, we'll talk about him, is 12 years or 13 years post-procedure. In fact, I saw his father the other day, and he's now in university, and the procedure was done in 2015 or something like that. And that was all he had. All he had was an ETV, and he didn't need anything else again. Even with children that have myelomeningocele, even though it's more technically demanding, the floor is thicker, the aqueduct looks something like this. The floor is very thick, so you do not see the anatomy as clearly as in other patients. You can still do ETV CPC with these kids. And even when you have something like this, which is, a brain that has very poor anatomy, the endoscope can still help you make sure that you place the shunt in the most optimal place to ensure that it drains properly. But what are the limitations? So it's not a magic bullet. It has limitations. When you have children with post-infective hydrocephalus, and how do you know that? Either from the history or when you put in the scope, you see deposits like this or scarring like this. It tells you that there's been infection. The chance is less than 50%, probably 30 to 40% that the procedure will work, and you may be better off putting in a shunt. Other limitations, if you have distorted anatomy or the CSF looks like this instead of looking like water, like I said, distorted anatomy, those are limitations to doing endoscopy. So, but these are things you can determine prior to going in most of the times. In terms of if you have imaging, you can determine whether the anatomy is good or favorable, and you can have that conversation with the patient, whether with the parents. So what affects the success for ETV CPC? The age. The older patient, the better. The ventricular size, the smaller, the better. If the patient has had a previous shunt, if there's intraoperative bleeding, that's not good because it will affect the ability of the body to heal. If there's cysternal scarring, and the extent of choroid plexus cauterization. So to the neurosurgeons in the audience and to aspiring neurosurgeons, if you do ETV, please make sure you combine it with a choroid plexus cauterization, because if you don't, especially if it's in a younger child, if it's in a child 6 months less, a year less, the chance of survival, of success, is less than 50%. But if you do, then you're making the chance of success at least about 70 to 80% that the child will not need a shunt. So what happens when the ETV fails? When the ETV fails, like in this patient, the patient had an ETV, but it had scarred over. All you go is go back and you reopen it, and you're back in business again. So that's one of the benefits of that procedure. I'm out of time. This is the child I was talking about. He was 7 years old when I met him. He had this. So this, he had what's called a tactile glioma. It had blocked the flow of CSF from the lateral third into the fourth. And it's not something you can get to by surgery. So what we did was that we did an ETV on him, and that was, like he said, 11, 12 years ago, and he's been fine since then. Okay. So this is him at the surgery, and this is 1 year after surgery. You can see that the brain is more relaxed. The ventricles are not yet back to normal size, but the brain is definitely more relaxed. And also, all right, I am going to stop here because of time, so that, yeah, thank you very much.
Thank you so much, Professor Bankole, for that lovely presentation. It's nice that the neurosurgeons are bringing us closer to their world. They used to seem so far away, even as medical students. So I'm glad that this is happening, and they're showing us inside the brain. We will never know if they didn't bring it to us. So I'm here again to introduce our next speaker. He flew all the way from the United Kingdom to be with us today. Thank you very much, sir. Distinguished Dr. Andrew Alalade. Please, may we have his profile? Dr. Andrew Alalade is a consultant neurosurgeon at Iwosan Lagoon Hospitals with specialist expertise in skull-based surgery, vascular neurosurgery, pituitary tumors, neurotrauma, and degenerative spinal conditions. Were you on the Dean's list, perhaps? He obtained his medical degree from the College of Medicine, University of Ibadan. I'm sure some people are excited. He is a fellow of the Royal College of Surgeons of England and a fellow of the European Association of Neurosurgical Societies. He completed his neurosurgical residency through the London North Thames Neurosurgical Training Program, finishing at the National Hospital for Neurology and Neurosurgery, Queen's Square, London. He subsequently undertook advanced fellowship training at Weill Cornell Medical College, New York, and the Princess Alexandra Hospital, Brisbane, gaining extensive international experience in complex cranial, skull-based, and vascular neurosurgery. Dr. Alalade is actively involved in education and leadership within the specialty. He teaches on multiple international neurosurgery courses and workshops and serves as a member of the EANS Diversity Committee. He is also the General Secretary of the Medical Association of Nigerians across Great Britain. In recognition of his contributions, he was named Diversity Leader by the European Association of Neurosurgical Societies, I beg your pardon, in 2022, and was recently nominated for the Acid Silver Scalpel Trainer Award 2025. From From 2022 to 2025, he served as Regional Director for the Northwest England Neurosurgery Teaching Program, where he played a key role in shaping and overseeing regional neurosurgical training. He is currently a member of the Neurosurgery Specialty Advisory Committee with the Joint Committee on Surgical Training, contributing to national initiatives to strengthen neurosurgical education and training standards. He is committed to delivering high-quality, patient-centered care while advancing neurosurgical practice through education, research, leadership, and international collaborations. What an extensive profile. Please welcome Dr. Andrew Alade, please. Thank you so much, sir, for being here with us.
Thank you very much, everybody. Really excited to be here. Really happy to see Tayo, other members of the faculty. Delighted to see everyone. There are a couple of other familiar faces. There's Chris, there's Babatunde, there's Chiazo. Happy to see everyone. The leadership of Iwosan Lagoon, thank you very much for inviting me here. I want to talk about skull-based neurosurgery. So I am a consultant neurosurgeon. I'm based in northwest of England at the Royal Preston Hospital. And my job was pretty much focuses on general neurosurgery, but more skull-based and vascular. Today I'm going to talk about skull-based and highlighting the systems. As much as all of us are hoping to be really good at what we do, we're very much dependent on the systems we work in. And I want to try and make everybody at least a neurosurgeon after 20 minutes. Do I get a yes from you? Yeah, good. And understandably, I was looking at the faculty, and it looks like I'm the only one in native. After wearing suit 300 days of the year, you want to try something different, so forgive me for that. So yes, so let's move on. This sits in my office and on my table and just reminds me about the skull base. Now, what is the skull base? It's the nook and crannies, the difficult parts to access in the skull. And I can remember when Professor Bankole was talking about outcomes and everybody was laughing. The truth is, with skull base, historically, the outcomes used to be dreadful because they're very difficult parts to operate on. I always tell people that medicine has improved so much. We transplant everything now. Eyes can be transplanted, intestines can be transplanted. What else? The heart was transplanted in the 70s. Lungs can be transplanted. The only two things that cannot be transplanted yet, the brain and spine, There's an Italian guy who was trying to do it, but I think he got into trouble and ran into jail or something, the brain and spine. So you want to protect your brain and spine. So what am I covering? I'm going to try and cover this. And the hope is that as the faculty here, as the hospital leaders here, we would be able to build up our practice so that it competes with what's really good. So I'll be covering these topics, and I'll be highlighting 10 cases. And yes, the skull base. So it's pretty much at the intersection. The neurosurgeons treat this, but we also depend on other specialties. The ENT, that's ear, nose, and throat. The eye doctors. I saw Hamid here as well. Interventional is really very important now in our practice. Oncology, endocrinology. I was telling BC I was excited when I saw that there's an oncology on the, on the moderator panel. There's a family physician, because it's very, very much dependent on systems. And gone are the days where you think you as the surgeon are the fantastic person who pulls all the shots. The truth is you have to be dependent on everybody to make sure your patients are alive. And what makes it more of a challenge, nowadays I'm coming to Nigeria quite a lot to see patients, and honestly my brain has to switch a lot because it's not, and that's why I, praise these guys, because when you're in the UK you don't think of anything else. You don't think of the microscope, you don't think about ICU care because there's an anesthetist, you don't think of anything. When you come to Nigeria you have to think about everything. You've got to, sleepless nights, you're just calculating. Sometimes you even use local anesthesia. You're just like, is this authentic or is this fake? You're not even sure. Everything is just going through your mind. So it's, and you guys should clap for them. You should clap for all the surgeons who are working and are pulling it off here. So what are the challenges? Late presentation with giant tumors, okay? The skull base very close to the nerves, very close to major blood vessels. They're traveling long distances. Usually for my skull base patients, most of them are scanned 6 months, every year, MRI, they don't think about it, you know. But, so follow-up has to be, you know, incorporated into the management. Blood products, neuromonitoring, ICU beds, you know, you cannot assume, you always have to kind of make sure they are available on demand. And reputation is built one well-selected, well-executed, well-followed-up case at a time. Some of the surgeries can be very long, and there is no shame in, you know, staging it. You can go in twice. You know, the main thing is to keep the patient alive. There's no point doing just one surgery and the patient is dead. It doesn't matter, you know, stage it. Think about the patient's life. So now, what makes a skull-based practice reputable is consistent outcomes, multidisciplinarity, where, and it's, you know, I can really say, and this is not bragging, I can really say that most of the neurosurgeons here, I have at least spoken to them at one point in or the other about patients or about a patient. Right size technology, you know, Bankole talked about that, and it would be good to try and get things like navigation, endoscopy, or even monitoring for certain cases. And it's expensive, but it does make a difference. Data and transparency, and I'll show some of my numbers at the end. A training pipeline, partnerships, whether regionally, internationally, locally, it all talks to that. Now, I've put a tiered system here. What's the foundation? Having high quality images, because the images help. Before a case, I always try to discuss with my radiologist, because even though you think you know quite a lot, the radiologist might offer you a different angle to cases. So I go sit with them, have a chat. What do you think about this case? The operating microscope, you know, Tyus talked about that. You guys have a fantastic one, that's good. Blood bank access, cross-match. You're growing up, you want to go to neuronavigation. You want to do rigid endoscopic for endonasal cases. Now in the UK, everybody gets told to do endoscopic. Nobody does microscopic anymore. That's pretty much routine. Intraoperative neuromonitoring, digital subtraction angiogram to look at blood vessels and to plan, because many times you get blood loss reduced significantly when the blood tumors are blocked. And then you go up to the high level, which it looks like you're even beginning to do some of that, because we talked about the LNEF, which is for skills transfer. So that's already happening. And then we need to start looking at our outcomes and audit cycles. Now, who are we dependent on? You see, neurosurgery is just one bit of this. There are many others. And I'm not, you know, honestly, this is just the truth, because you have to be part of a team. You have to work with other people. You have to work with ENT and rhinology. You have to work with your anesthetic team. It's very, very important. What kind of gases are they given? You have to work with your neuroradiology team, critical care, pathology, oncology, hormone doctors, eye doctors. You've got to work on them if you're going to do skull base. Because all of these tumors, there is a lot of overlaps. So if you're going to do proper skull base, you need to try and befriend all these people in your hospital, put them on speed dial, your favorite list, and be able to talk to them. And honestly, in my hospital, I have one person who's my pal in all of these departments. It's just part of the game plan. Now, weekly MDTs, we do this all the time. So every Monday, 12 noon, we would review all referred skull-based cases. So we look at all the cases we image. And the truth is, I look at some of these scans before I have a plan in my head, but then someone says something different, and it just makes me think differently, you know? And if it's a really good idea, then you implement it, and the patient, you know, gains from it. And we operate, and even after surgery, you want to debrief as well. You want to look at what did you do well, what did you do wrongly. Now, let's talk about a few cases. And these are personal cases. I just went through my archives and just handpicked a few of them. Now, this was one that was referred, and you can see this stuff here. And I think, Chris, I think I showed you these pictures when I first got them. and you can see the blood vessels there in the tumor. So of course, you look at this, there's a lot of shift. This is a tumor here with big blood vessels. And so yes, I knew that definitely I had to speak to the interventional radiologist. So if this was in Lagos now, you know, I'll call someone like Hamid, I'll call Uche, and I'll say, please, can you block this off? And the surgery actually went a lot better than I expected because I was able to block off the blood vessels, right? So, you know, and I'll be looking at the cases where, and, you know, looking at estimated blood loss in cases that I've done with angio. And, you know, sometimes you don't get a good margin. You can't peel off the tumor as much. It doesn't deliver as much. But in terms of blood loss, it's significantly less. Let's look at another one. This is something called a cranial. Yeah, this is another one that tends to worry you a bit. It's bang in the middle. It can cause different problems. Not because it's in its nature itself, it's not a bad tumor, but because of where it is, because it is near the hypothalamus, because it's on top of the pituitary, the chances of you getting there with minimal injury is quite low. So you want to, you know, pretty much decide what are the best angles of attack, how you're going to get to it, get your endocrinology team to monitor, because sometimes the pituitary stalk goes off and all of that. This is another one. So this one here, if you look at the tumor, there's a big blood lake here, and the tumor was going into it. So with this one, we just did imaging to kind of plan properly so that we could get the tumor without causing the patient to bleed. Okay, so we just got this and kind of stayed and left a tiny rind there. Which one? Okay, yeah, and when you look at this compared to that one, this one was a lot more easier. So it just went in, and this was much easier to get off than the previous one. Yes, and sometimes we have this one. A lot of people, you don't know that they've got problems with behavior. Funny enough, this patient was actually really good, really fine. When I saw her in clinic, we ended up talking about tennis throughout the whole clinic. But sometimes you see people with large tumors like this. And how do you get them out? You have to aim to devascularize first from the base and have a realistic conversation with the patient. They're going to probably lose their sense of smell, as well as any other side effects that are possible. Yes, this was one where I worked with ENT. This was a young chap who had hit his head. Fortunately, he had, for some reason, he had gone to the hospital about 4 months before, and they did a CT. The CT was absolutely fine. There was nothing on the CT, and this was 4 months. And within 4 months, he was unconscious, and he landed in the hospital with this. And I thought it was probably something called anesthesia. But then by the time we had to go in from the top, did a transcranial, and then went in from the bottom as well. And then we took some calvarium here and then laid it across pretty much to repair. But this came back as an olfactory carcinoma, which is the one case I've never seen any other olfactory carcinoma. And he had a Ki-67 of 40. Most times when you see tumors, Ki-67 just tells you how much they can recur, how much the speed of growth. And usually most tumors I see 1 to 2%. So 40 was alarming. And then we had to refer to oncology, and then they treated him pretty much with chemotherapy. These are vestibular schwannomas. The main issue here is they're attached to the nerves that move the face. So, you can do beautiful surgery, and the patient comes, especially if it's a young patient, and they can't move their face. And that means lifelong they're just going to have a wonky face. You don't want that. So to be honest, it's better to leave some tumor rather than have a patient who has a deformed face. So that is always priority. And the good thing now is even if you leave a tiny bit of tumor and it grows, then you can refer to your radiotherapy colleagues and get them to treat with radiotherapy. This was another lady. In fact, this lady 2 weeks ago actually contacted the local papers because she was going to talk about how Mr. Lalade had helped her. It was an alarming one. She had radiotherapy as a child, lots of tumors, and took off one on the right side and then took off this one on the left side a week after. And she's done really well. And these are the kind of cases, big surgery, and she pretty much after the second surgery went on pretty much within, I operated on her on Wednesday and she was home on Saturday. after her second surgery, and she did really well. Yeah, and yes, neuronavigation is important. It makes things much easier. It does, definitely, because you're checking where are you, because sometimes within the brain you can get lost, okay? Some heads might look small, but the truth is when you're deep in there, it might, you get lost, and every neurosurgeon knows that. So it's helpful, and I think that's next level. And I'm only saying it because I think it's something we should probably think about for the future. You're getting it, good, fantastic. I'm sure that will be beaming with smiles. Okay, and yes, it's good to have protocols. Protocols are very important. You should have standardized protocols, and it should be pretty much everything covering how you manage the patients before surgery and during surgery. And also having critical care protocols about what happens after the procedure. Where do you document? Where do you write it? Does everybody know about it? Does the ICU team know about what should be done? Who do you call if there's a problem? Because neurosurgery is one of those things that sometimes I think you can't be too nice as a doctor in neurosurgery. Because if you're too nice and members of your team get lax, then a patient just dies. It's as easy as that, So sometimes you got to be firm, and it's always a dilemma for me because you want to smile with everybody, but at the same time there's a patient's life at stake, and especially in environments where if there's no structure yet, then you have to make that structure and make people accountable. Yes, so how do we achieve excellent outcomes here? First of all, be careful about patient selection, and even I am learning about this, how I'm evolving with time. Who are the patients you should go for? Who are the patients you shouldn't go for? Have regional partnerships, be able to discuss with people, because no man is an island. Get the right size technology, even if it's the basic one. And I would think nowadays the basic set should be a microscope, navigation set, endoscope tower, and all of that. Task sharing, training, outcome registry, and telecollaboration, very important. And what are the things you could look at your outcomes for score base? You could look at how much of the tumor have you taken out? Did you preserve the nerves? We use something called the 30-day mortality. They check whether your patients died within 30 days, and your follow-up completion. So everything is well documented and audited, even at a national level. So at a national level, they know everybody's figures. So training, partnerships, and sustainability. You should also think about the future. Are you training the next generation? If one neurosurgeon leaves, who's going to be taking up the cases in another 20, 30 years? Are there shared MDTs? Do you have second opinion pathways? And sustainability, what are you doing in terms of, and conferences like this one is quite good. So you shouldn't stop at this. You should aim to do more of this in the future. Now, I was looking at, since COVID, I was looking at pulling up my score base, just the score base numbers, not spine, not vascular, not the rest of the other things. Just focusing on score base. And there are 315, and there's a breakdown, pretty much 6 tumor types there. Pituitary seems to be trumping, and that's because we have a select kind of Fridays. Every Fridays is pretty much for pituitary, so you always get to put one on your list at least. Meningiomas, all the score base, it can be whatever. Petroclivus, different types of, and then vestibular schwannomas, and then cranials, and then under the others, there are all those like chondroid or other lesions, and then epidermoid cyst. And there are two cases that I've lost 30-day mortality. One was a petrocliver, and one was, the latest one was a younger lady who had a really vascular lesion in October, which I don't think I've still recovered from, that's the 2 ones, so that gives me my 0.6 figures. And in terms of gross total resection for me, for vestibular schwannomas, I was looking, so we have every case you do, the radiologist reports it. We have a 3 Tesla MRI, and they will report it. And sometimes I tell the radiologist, is it that you guys don't like me or what? Because even if they see some dots, they will say there is residual tumor, So gross total resection from a surgeon is very difficult from gross total resection from the radiologist. They report things differently. So my vestibular schwannomas, I would say 64%. I don't count, I didn't put near total here. Near total is more than 95, but I don't count that. And yes, I do think about the facial nerve and neurovascular structures, and I do tell the patients about it as well. I tell the patient that if it gets to a point where I'm not sure, I would leave some tumor because I don't want this to happen to you. And ICU, pituitary cases or posterior fossa vestibular schwannomas would all go to ICU. The other cases do not go to ICU. But that's because we have a good team that can manage, you know. Here in Nigeria, I'll probably say everybody to ICU. And yeah, that's median length of stay. And this is pretty much looking at recurrence numbers. Now, I did say that when we look at the scans and there's recurrence numbers, you just send them straight for a radiotherapy consideration. So there's always that backup plan of having radiotherapy to help to freeze the tumor, because radiotherapy keeps everything under control after you have done the job of taking off mass effects. And comparing with what's in the literature, you can see that, you know, somehow I kind of sit between those figures. Now, what are the key takeaways? I'm wrapping up now. It's a system. It's not just a surgeon. It is a system. So the focus should be on developing a system. You can have a central figure in the middle, but it's all about focusing on the system, and it's about repeating the same patterns. You know, your team has to be used to the same patterns. You get into theater, you talk the same language. You come out of theater, you talk the same language, so that people are used to habits. And excellent outcomes, it's all about selecting the right patients, keeping your tools well maintained, data, honesty, honest reporting, and that's why I put that, because until we start to report figures, you know, a lot of things get swept under the carpet, so you have to show figures as well. I put a picture of my dad there. About 30 years ago, when I was in medical school, my dad, there was a call, we got a call that my dad had collapsed, and mumbling gibberish, and he was diagnosed with an olfactory groove meningioma. And that's one of the reasons why I think probably pushed me to become the neurosurgeon I am today. And I can remember then, you know, they were talking to us and everything was just entering one ear, going out. And then I tell my patients that when they come in, I say, listen, I've been on that side as well. I understand. And I think that's why I'm very emotionally invested with my patients. And I think a lot of us all have our own individual stories. And yes, I want to pay, you know, again to these guys. This was me 2012, around the time that paper came out, and I was in with Professor Oyesiku in his office. I spent a month with him. That's Tayo when he still had black hair. Now he doesn't anymore. That's James. I've known James for over 2 decades. And that's Hamid and, you know, and Uche, lovely guys. And that's the guy who keeps getting young. I don't understand what's going on. Yeah, thank you very much, everybody.
Thank you very much, Dr. Andrew Alalade, for that very engaging presentation. So before we move on, I would like to please implore everyone to write down their questions, type it on your phone. I know we've heard so much, so let's write down our questions. We're going into the panel session very soon, so please put down your questions. So this next segment, the last Doctors Forum, we had a patient that was very excited. You know, she was telling us that we should, you know, engage patients in when we do things like this, so that we should hear their side. So I'm very, so the person that decided that we should put this segment, kudos, thank you for that. So this segment, we're going to be hearing from a patient that has benefited from the expertise of our neurosurgeons here. I would like to welcome Mrs. Oye Olabode. Is she here with us, or is she joining online? All right. Thank you, ma'am. Please come up to the stage.
Thank you. Good afternoon, ladies and gentlemen. Good afternoon, neurosurgeons here present. Good afternoon, Dr. Ojo. So I'm just going to be giving my testimonial through brain aneurysm survival. And first, I thank God for the privilege to be here. I give God the glory for the privilege to be alive and have all my members, working. Okay, so my journey started in 2024. I was about 39. It was some months to my 40th birthday. And I noticed that I was having these consistent headaches. It was whenever I woke up in the morning, I would have those headaches, but then during the day to dissipate. But the peak of it was one day when I was home alone, and I started having this wicked, I'll say diabolical headache. It started from here, all the way to the side of my head, to the back of my skull. At the same time, my left side, I started feeling pain on the left side of my body. And because I was home alone, what I did was, okay, I tried to calm down. I tried to open the door, so in case I collapsed, because I felt I was going to collapse. In case I collapsed, my neighbors at least can see me and someone can come in without having to break the door. But I managed to call my husband from work. So he came, he took me to the hospital, and they said it was migraines. They said it was migraine. They said my blood pressure was a bit elevated, and they treated me for migraine. So yeah, so I was in hospital, admitted for 2 weeks, that hospital. So not Lagoon. So I was admitted for 2 days, and I was discharged. I was asked to come back a week after. And I went to the hospital a week after, and I was told that everything was fine. But that same day, as I got home, it wasn't up to an hour, this headache came back. And this time around, my kids were home, and then I started feeling this headache again. And this time around, the intensity was worse. It was like something was grinding through my skull. At the same time, the whole building was on my head. So I collapsed. This time around, I lost consciousness. And thank God my kids were home. God used them to, because they did CPR for me, and then they rang their dad. I woke up, but they rang their dad, so he came and he rushed me to the hospital. And then at that hospital, I was told they did a CT scan, and they found nothing. Said I was fine, that the only thing was that I needed to be using blood pressure meds, which I started to use. And this was 2024, January, February. The first episode happened in January, second happened in February. And so I was living out my life thinking everything was fine. 2024 ended, and guess what? A year and 8 months later, October 24th, 2025, this headache came back. And when it came back this time, it was almost devastating because I was home, but thank God that my kids were supposed to go to school that day, but for some reason it was sports day in school. And because it was sports day and they were asking us to drop them at some weird time, and we're not sure with everything happening in Nigeria, we're not sure whether to drop them at that time. We said, okay, sports day, maybe we should stay home. Sports, you guys can have sports at another time. But thank God that they were home, because when that headache started again, I was in my room. I had to find my way out of the room to make sure that, because it was in the morning, to make sure that my kids saw me so that they'll call for help. And so one of them saw me, and that was how, this was 8:30 in the morning, and this was how my journey, to Lagoon started. And at 8:30, after they called their dad back, the dad got back at about 11. He took me to this hospital that I was using at the time, and they did not touch me. I was unconscious. I was not responding. They didn't touch me. They said that they should take me to another hospital, a teaching hospital, where I was taken to. And from there, I wasn't admitted again. This was about 8:30 to 1 p.m. My husband telling me this afterwards. So 1 p.m., taking me from place to place until 6 p.m. when I was taken to Lagoon Hospital that same day. So imagine being unconscious, in and out of consciousness from that time. Then when I got to Lagoon, they did a more detailed scan, an angiogram scan, and discovered that I had multiple bleeds in the brain. I had multiple ruptures in the brain, and then I was slated for surgery. And I remember during the preparation for the surgery, my memory of that time is a bit sketchy, but one thing I remember is that Dr. Tayo came and was telling me things that could happen, and I know I was scared. I was like, oh my God, I was scared because I could go blind, I could be paralyzed, I could have speech impairment, and of course amnesia and all of that. But then the surgery was done, and I think I can say I fully woke up like 2 days after the surgery. This was October 27th, 2025. That was when the surgery was done. And then it started to recover. My leg, the left side I said I experienced, the left pain, I had those pains initially, but then with time, I could move my leg, So I'm grateful that God used Dr. Tayo, Lagoon Hospital, to pretty much save my life. That's about my testimony of my journey through brain aneurysm. Thank you so much, ladies and gentlemen.
That was an heartfelt, touching story. Thank you so much, neurosurgeon. Thank you so much, Dr. Tayo. Thank you, Iwosan Lagoon Hospital, for giving us this platform. Before I call on the next presenter or speaker, please, I want to ask us a question. How many neurosurgeons do you think we have in Nigeria at the moment? How many neurosurgeons do you think, or how many are we in Nigeria, give or take? Please answer. I have 30 seconds for this. How many are we in Nigeria, give or take? Over 200 million, right? How many neurosurgeons do you think we have in Nigeria? Somebody once called them endangered species. So when you see neurosurgeons, it's a privilege. Hello? It's a privilege to have brightest mind in our midst. Let's appreciate the neurosurgeons in the house again. So we are getting to we are moving. Before I call on the next presenter, I just want to remind us, if you have questions, clarifications from all our speakers that have spoken, Professor Nelson, Professor Femi Bankole, Dr. Andrew Alalade, and the next person I'm going to be calling on, Professor Balogun, right now. Please, I want us to jot down our questions. Whatever question you have, clarification, anything, please let's jot it down. And we'll move on from them, because after this presentation, we are going to be having a panel session, and we need us to ask and engage them. So it's a privilege to have them. Really, I don't think we have up to 150 neurosurgeons in Nigeria. I don't think so. You can fact check me. I don't think we have up to 150 in Nigeria at the moment. Okay, so please let me put it up. DJ. Professor James Balogun will be talking on glioma surgery in Nigeria, the onco-functional resection dilemma, current wins and future frontiers. Okay, I think I like this one. I'm a radiation and clinical oncologist. So this one resonates well with me. So Professor Balogun James is a professor of surgery at the College of Medicine, University of Ibadan. Is an honorary consultant neurosurgeon to the University College Hospital, UCH Ibadan. He's present head Department of Neurological Surgery, UCH Ibadan, and completed a clinical fellowship in pediatric neurosurgery at the Hospital for Sick Children, Toronto, with clinical fellowship in adult neuro-oncology from Toronto and Manchester. He was the pioneer and immediate past president of the Society for Neuro-Oncology Sub-Saharan African, SNOSSA, and also a past co-chair of the International Outreach Committee of the Society for Neuro-Oncology, SNO. He has served on the Neuro-Oncology and Pediatric Neurosurgery Committees of the World Federation of Neurological Society, that is WFNS. And presently, he serves as the vice chair of the liaison committee of the International Society for Pediatric Neurosurgery. He was also the track leader of the Education Committee, CNS, track for 2026 ASCO annual meeting, and is also a member of Scientific Program Committee, SNN track. Professor Balogun James is also a Lancet Commissioner in the Lancet Commission on Neuro-Rehabilitation of Neuro-Oncology Working Group. His research focus is on epidemiology, science, and surgery of adult and pediatric brain tumors. His clinical practice is largely centered on endoscopy pituitary skull-based surgery, minimal access cranial surgery, awake and same-day discharge craniotomy service. Please welcome with me Professor James Balogun. Thank you, sir.
It's a great pleasure being here, and I want to thank the organizers, particularly the Iwosan Lagoon Hospitals systems, for this opportunity. I also want to acknowledge Professor Oyesiku, who is online. I think he's a great mentor to almost every one of us here. I work at the Premier University and at the University College Hospital in Ibadan. So it's also interesting actually to listen to patients and patient advocates. I belong to a society where we don't only have professionals, we also have patient advocates as members of that society, and knowing the implication of that and also hearing their stories. It's a little bit difficult for me. I'm going to go through my slides. It's kind of a little bit neurosurgery heavy. I was conflicted in trying to kind of figure out the audience, but I will just obviously just go through so that I have messages to everyone. And I think the first three people who have spoken have actually spoken my mind. Professor Oyesiku spoke about pituitary surgery. Andrew talked about skull base. And then Professor Bankole talked about intraventricular endoscopy. So really, I think that what we are trying to do today is just being advocates. And advocates for our patients, advocates for a great system, and advocates for also pushing the frontiers in terms of practice for us as practitioners. So on a general note, it's just being advocates. So if I can have the slides on, please. So they've given me, I don't know why he chose one of the difficult diseases in neurosurgery. And then, obviously, if you look at that, I think you can just summarize that as precision surgery in gliomas. Gliomas generally are really difficult disease to treat. They go from a panel of very benign diseases to the most malignant disease that you can deal with as a neurosurgeon, which is why the co-moderator, who is a radiation oncologist, would obviously be in the room pre-operatively to decide what we do, and then post-operatively how we do follow-up on the patients. So I've got no disclosures. So basically, our lives became a little bit complicated more in the LMICs and in Nigeria as well, following this change in the classification of brain tumors. Initially, they've gone through a lot of revisions, but in 2016, what I need you to pay attention to is that the diagnosis of this spectrum of diseases, particularly brain tumors, became much more important because molecular markers were incorporated into that classification. In other words, just doing an H&E, hematoxylin and eosin, does not give you a real diagnosis anymore. You have to go ahead to do molecular markers. And so that changed everything for us, particularly in what you call the global south. So basically, I'm not sure you can see a lot of these. I'm just trying to show here the spectrum of what we call gliomas. They go from very benign diseases, very well circumscribed diseases, both in children and in adults, to the most malignant disease that's called the glioblastoma. We've removed multiforme, just this is an indication. So we don't call it glioblastoma multiforme anymore. And that class that we call the most malignant disease is now subclassified further based on molecular markers. So when we see it, it's not just the disease that we want to see. We want to see what exactly is the biology of the disease. So just as an illustration to know this is not too far from us. Obviously, everybody's talking about this meningioma, but don't forget, gliomas are also present with us. So even though most people are very, they're very familiar with pituitary tumors, meningiomas, gliomas are also there in the mix. In children, they're actually the most common. And you see there where I said they're mostly NOS, it means not otherwise stated. It means that from Africa, in sub-Saharan Africa, from this study, what we found is that we do not have molecular markers for most of the things that have been reported. So they're otherwise non-stated. So basically, the role of surgery in gliomas. Really, we want to have a diagnosis. So with the biopsy, it doesn't matter whether you remove a bit of the tumor, you remove the whole of it, you remove some parts of it, it gives us a diagnosis. First thing. The other thing is that when you do remove the tumor, you cytoreduce. It means that you reduce the bulk of the tumor. That gives the brain time to breathe. And then you have reduction in the intracranial pressure. And if the patient does have neurologic deficits, that neurologic deficit may then improve with everything that you have done. So, but you see, just as controversial as this disease is, there has been an evolution in the role of surgery. So let's take the low-grade gliomas, particularly what we call the diffuse gliomas. So in this study compares two hospitals. So you can imagine two hospitals in Lagos. One will not operate when they see the MRI findings of a low-grade glioma. The other ones will operate. So comparing the data from the two hospitals, the question was, what was the overall survivor? And it was found out that surgery actually improves the overall survivor. However, listen to this confusion. So this, again, just shows this graph. The hospital that is operating, the survival is more, and you can see the wideness, the width between that and non-operating. However, just about the same time, these guys from Italy then concluded that there's really no difference between watching and operating. So we got into dilemmas just because of a disease. But on the overall, we know the principles of surgery, and then we also know that whatever you do in surgery, you either take a biopsy, you either resect the tumor and leave some, just like some of my colleagues have said, and you can do a gross total resection. So we know that you go from biopsy all the way to gross total resection. Now then come in another study that blew everybody, and this was more in a high-grade glioma, telling us that how much, this is not even whether surgery was okay. We all have agreed that surgery was okay and that surgery improved survivor, but to what extent should surgery be done? So here, the green graph that you see says if you can remove 100% of the tumor, the survival is better than the least here at 60%. So the more you remove, the better the overall survivor. And in fact, the better the progression-free survivor, meaning that the survival of the patient, the time interval between when you resect the tumor and when the tumor does come back, if it's not going to come back, is better if you do remove the tumor. So the more you remove, the better for the patient. Now, the question is, you want to remove all the tumor. If you do remove the tumor and the patient does have deficits, new deficits, it also affects the overall survival of the patient. So there has to be a balance between how much you remove and whether the patient does have deficits. So the concept became a little bit modified to say, should we just remove all of what we see, or should we remove more? So for the people who are colonic surgeons and those who are breast surgeons, we remove tumors and then we leave a margin. The question is, can you leave a margin in the brain? However, this concept came to be, it's called supratotal resection. You do not only resect what you see as the tumor on MRI, which is contrast enhancing, you remove the one that is also around the tumor that is not enhancing. And now you have to balance the extent of resection with not producing new deficits in the patient and being able to give the patient a chance to have an improved overall survivor and progression-free survivor. So you're between the hard rock
You're between the rock and the hard place. So it's a delicate balance. So the paradigm shift, which is what I actually want to tell you, is that it then becomes an oncofunctional philosophy. You've got to balance how much tumor you remove and the quality of life. Our sister who just left here said something. She's not just grateful for being alive, she's grateful that her members are working. Now let's put it contextually. It's not just about your members working or the patient's members working. It's about being also able to continue to live independently and perform as what you were doing before the surgery. It becomes more complicated because now it's relational with the patient and what the patient actually wants. So, obviously over the years we do have milestones that have taken place in neuro-oncology, but I'm a surgeon. All of these, there's quite a number of them that have to do with pathology, a number of them that have to do with imaging, but then what gives us that opportunity to maximize what we resect, balancing it with the quality of life, are the tools, or what you call the baby tools that we can play with in the operating room, before, after the surgeries. So, adjuncts. Everyone here, I think Andrew did mention, we've got things. So you got a Kinevo microscope, absolutely fantastic. The question is, before you get to use the Kinevo, what would you do? Because the Kinevo will guide your resection nicely because of the visualization and because of the optics. Beautiful. But before then, what do you do? And with the microscope, what else can you do other than just looking at the tumor and resecting the tumor? So here, most importantly, preoperative MRI. And I'm throwing this to those who are the real people who will determine policies. Most of us would base our decisions on anatomical sequences of MRI, but we forget that there are physiologic sequences and there are functional sequences. Now the functional and the physiologic sequences will guide to tell you where the tumor is, how much the tumor is vascularized, and the functions of the brain around the tumor. But obviously in Nigeria, we do have a lot of MRIs, and the basic things they do is just anatomical views, tell us where the tumor is. But this is more than that. So we also know that we should localize where the eloquent regions are, and then the techniques to remove the bone as well as the tumor. So look at this tumor. The tumor is here. Look at the fibers. This fiber is either motor fibers, right, or language area fibers. Just assume what they are. If a surgeon in this part of the world has this access, it's easy. Everyone in the room will be able to decide how to get to the tumor. This way. If you come this way, this guy is in front of you. Patient is going to develop a neurologic deficit. Now, this is the key. We do awake craniotomies now and brain mapping, meaning that patient is talking to you, and I'm sure that quite a number of people are familiar with those stories on YouTube or something. So a patient comes in, 29-year-old. All he does is he sings. And then he has a tumor in his motor speech area. And he tells you, whatever you do, make sure I can sing. So your question now as a surgeon is not that you cannot remove the tumor, but you have a patient who has told you categorically, remove whatever you want to remove, but please, I want to sing. In other words, your surgery is failure. If he wakes up, tumor is out, but he cannot sing. So you have to put that into context. So we do awake craniotomies and we map the brain. So the brain is open, patient is awake, and he's talking to you. So if he says, I want to move my hands, I don't want to lose my fine motions, you have to test for that. If it's the speech, you have to talk to the patient and prepare the patient for that. So the question is, obviously, I'm not going to bore you. Like I said, this is a little bit neurosurgical heavy. So there are reasons why we do them, prior consents and all that. So, but this guy is a French guy, and he says, it's not no longer an alternative. It's actually the philosophy that should we buy into. All right, but then the challenge is you have to have all that it takes to map the brain. However, what I challenge my colleagues always is we could also do awake craniotomy without mapping the brain. It's another dimension. But if you want to do what is high level, then you need to map the brain. So it's also possible in children. My fellowship, we did some of these procedures on children. Adoption, so we need it, because if you do awake craniotomy, it also saves you a lot. You don't need general anesthesia. You do local anesthesia, use propofol infusions, wake up the patient, and afterwards, patient is fine. You don't need intubation. You don't, most of the times, need ICU care for this patient. So it also saves resources. But look at the adaptation in LMICs. Slow, okay. But then, this is an example. So this is a tumor which is periroladic. You see where I'm putting my scope is right on the motor area. And this is the Rolandic feature that is taught to medical students from anatomy. This tumor straddled there. This was a 69-year-old surgeon in Nigeria. So you need not only remove the tumor, you need to preserve his functions. So we did this awake craniotomy and map his brain. Beautiful surgery. Look at what is left. This is just the cavity where the tumor was. Man woke up, used his hands, use his legs and everything. That's beautiful. That's what you want to do. That's what you want to aim at. There are challenges? Yes, absolutely. But it can be done here. So the next question is, you can also operate on these patients. You can also operate on these patients and actually do what we call outpatient craniotomy for brain tumors. So patient walks in the morning, you do the surgery, patient walks home, and they come back for checkup the next days. So this was the first series that we did in Ibadan. So it's possible, and in places where you even have resources, this is actually possible. So I'll round up because now I see I'm running out of time. I have just 4 more minutes. Now look at what Dr. Alade talked about, and patients come to you initially. Just series of MRI. Look at this tumor. Was seen on the MRI. Nobody was sure what it was. 6 months later, this is what the tumor looked like. Another 6 months later, this is what the tumor looked like. By the time the patient presented to us, this is what the tumor looks like. Look at it. That's the tumor. Now, this was a 35-year-old mother of 1 who is working, now has motor deficits. The question is, what do you do? So now the question is, as neurosurgeons, I like the fact that we relate so well with our other specialties. When you come back and you look at this MRI, it looks hypo-intense all through, but when you get here, you see this tiny hypo-intensity. It sends a message that is this low grade going towards high grade. So we did MRS, magnetic resonance spectrography, and you see this green part. It shows that that part is already getting malignant. So the question is, as a surgeon, you not only remove the tumor, you have to remove the part that is enhancing. No, it doesn't matter how much you do. So we did I don't know if this is going to play just for 1 sec. How do I play that? If I, okay. Okay. So can you play it quickly? So you see, the brain is open here. I'm putting up the electrodes, and she's moving her hands so as to be sure that as we go, wherever we're going to go through, we do not injure her hands, right? And the same thing with her foot, because she had a foot drop, and we had to do the same. If you played, she's going to try, but you will see that the feet is really not moving so much. So the question is, we just need to be careful not to render her more injured from the surgery. So we did that, and you see the cavity, we had to come from posterior to be able to go towards that tumor. Fortunately for us, we got both sides, and both sides came out with 2 different histologies. See, so now the question is, with what histologies do we treat her? Obviously with the higher histology. So it turns out that it's a diffuse grade 4 astrocytoma, but you see this immunohistochemistry of IDH mutant changes everything for her, because this is a more better prognosis than if it was not there. So this is precision. Each patient is different. You have to focus your mind on not just removing tumors, but but also improving and maintaining the quality of life of these patients. So again, if you play this, these things are possible to have. This is just QSER trying to resect in this cavity. This is Cavetron ultrasonic aspirator right here. So you can use that to, again, rebuke the tumor so that you know how much what you're doing. So obviously, there are different things that we can do. People have talked about neuronavigation. It guides you straight to the tumor. It guides how you open the bone and all that. I won't bother you, but what I can tell you is all of this would improve the extent of resection of the tumor and also help you to guide in terms of what the overall survivor. This is not so common, even around the world. But check the next slide. Almost every hospital has an intraoperative, has an ultrasound. And you can actually get real-time diagnosis of brain tumor, and as you resect, get feedback from the ultrasound right there in the operating room. So again, low-hanging fruit, but we're not familiar with it. We want intraoperative CT scan and MRIs. Worldwide, only very few people would have it. So I think for this is people like Andrew would have access to it. However, the microscope in Lagoon can actually do this because it needs a blue filter. And that's probably the only microscope, apart from one or two, which are also Penteros, which can do this. What you do is when you give that drug, look at this. It looks normal to you as a brain, and this looks like the tumor. But look at that fluorescein. This shows that all of what you have in front of you is actually tumor. So it can help guide surgery, and it can help guide tumor resection. So again, this improves that. Obviously, for those of us, you can also do mini craniotomies. Professor Bankole is going to put a smile on his face now because he knows where this is all coming from. And this is possible out here even without that. And obviously, I mean, for those who have the access to it to do robot-assisted surgery, my conclusion is that for even the most difficult tumors, in terms of their biology, surgery still remains a major role, plays a major role in the treatment algorithm. You can use all the adjuncts that you have. Obviously, multidisciplinary collaboration is key. But this is my final slide, and this is where the issue is. Fatalism, I think, is the most important thing to improving glioma surgery. Do not count anyone out until you have given them the chance to very good health care. And thank you, everyone, for listening.
Awesome. Please, a round of applause, please. Awesome. Awesome. How are we learning? That's very good. At the point I was thinking maybe I should just switch. Because they made it so simple and so easy. Thank you very much, Professor James, and other speakers that have come to present to us, to let us know new things about what you do. Most of the time, people, non-medicals, non-clinicians, people that don't know what we are doing, they don't even know what you do. But I tell you, we that are doctors, we that are also in the field, in healthcare, we know what neurosurgeons are doing. These are disciplined people. They are very disciplined. They are consistent. They are hardworking. They are dedicated. And let's give them a round of applause. They are awesome people. They are highly motivated. They are highly motivated people. Awesome. Thank you very much. So we are going to question and answer session where we are going to call up all the panelists, all the speakers. We are going to be calling up Professor Nelson is online, but we are going to be calling on Professor Femi Bankole, Dr. Andrew Alalade, and Professor James Balogun. So before we call them up, I just want us to write our questions in a sheet of a paper, and please pass it. And if you want to ask them direct question, we give you a mic, and you can ask whatever question you want to ask about neurosurgery. We have medical students here that want to know, okay, how can I join? How can I be part of this team? Or something that you've read that you don't understand, or something you want to know about anything. And concerning their presentation, you have any questions you want to ask, please let's pen them down. We don't have much time, less than 20 minutes. We're going to be doing this. please let's all get started. Okay, and before I call them up, I just also want to welcome everyone that have come around, all the neurosurgeons that are in the house, aside our speakers. We welcome you, we appreciate you, we recognize your presence. All the physicians in the house, we also recognize your presence. Our captain of industries that are here, we also recognize your presence. Top executives, we recognize you. Medical trainees, we also recognize you. We really appreciate that you guys came around. So without much ado, let me call Professor Nelson. Please, are you online, sir?
I am.
Oh, thank you very much, sir. So we are calling you up. We are calling up Professor Femi. But let's welcome them, Professor Femi, Dr. Alalade, and Professor James Balogun. Thank you very much. I think it's a privilege for me to be among my teachers. Thank you very much for coming. Please, do you have any question? Anyone from the audience? Okay, we have one hand. Please, can you help me give? We have two. We do it fast. Thank you, sir.
Where's the person? Where's the person? Okay.
Please be faster. Over there. Yeah.
Can I? Okay. Sorry, how would you like to?
Hello, everyone. Good afternoon. Good afternoon, surgeons.
Good afternoon.
My name is George. 3 years ago, I lost an in-law, a young man, just like me. And his case was just similar to the lady that gave a testimonial, headache. And when he went to the hospital, they told him he should go home. That is something I can go and manage and come back in 2 weeks. Less than 2 weeks, probably 3 days after he started screaming, my head, we rushed him, and then that was it. It's a very painful loss because this is a very bright young man who started a family, had twins. And we thought this is actually someone that had a very bright future. So when I saw the doctor, I didn't know how to feel because I felt he should have done better. Because after testing him, he should have known, is this the kind of ailments that he should get serious medication for, or what else to do. But at the end, we couldn't, of course, he can't do anything. So I want to know, where do we draw the line for doctors to know exactly what to do in a situation where they don't have even more than how you came in? Can we break down this to a layman terms? So when you are calling all these terminologies, even as you are speaking, let me understand it in Igbo, in Yoruba, in broken English, that I can be able to know that this is what is wrong with me or with my family member. Because at the end, till today, most of my family members still believe that it was a spiritual attack from a family member who they are dragging house or property with. So these are my questions. Thank you.
Who is taking a question? Okay, please. We will answer the questions all together. So we've noted that. Thank you very much, sir. Please, can you?
This is the second person. Oh, sorry.
Sorry.
Okay.
Please, hello, sorry. So we want it to be very fast.
All right.
So please, if you have questions now, please just raise your hand so that one question will not beget another question. If you have question now, please raise your hand. So we have
is this, directed to Dr. Bankole. You mentioned that for post-infective hydrocephalus, you'd want to use a shunt and not a ETV for those patients. But earlier you had said that shunts they are prone to infections, and this infection could lead to the demise of the patients. So I want to ask, when using shunts for these post-infective hydrocephalus patients, is our aim just to prolong their lives, so that they don't die immediately, or is there are we trying to definitively cure the post-infective hydrocephalus? And also, is there an equivalent for ETV? As good as ETV, is there an equivalent for these patients being post-infective hydrocephalus? And my second question is directed to Dr. Alalade. You mentioned that for the skull-based neurosurgery, there are patients that you should and should not go for. So my question is, for the patients who do not meet the criteria to have these surgeries, what is the hope for them, or what is the outcome in those cases? Thank you.
Okay.
Good afternoon, everyone. Good afternoon, surgeons. My name is Dr. Prince Will. I'm founder of Clarimed. It's a clinical care coordination digital health app that's also powered with personal medical records to enhance care coordination. So my question goes to Dr. Andrew Olalade. In fact, I have one question and one request, but let me quickly go with the question. Now, given the shortage of neurosurgeons in the country, I don't know, is there a role, or what role do you see the digital health platforms and telemedicine playing in decentralizing neurosurgical care for people in Nigeria and Africa generally? And my request is, I don't know if I can have 5 minutes with you after the symposium. Thank you very much.
Please, next person, the doctor over here.
Who's the fourth person?
Good afternoon, everyone. I'm Dr. Wahab, a radiologist. And I'm happy to be here once again to listen to my teacher again. Professor Femi Bankole was my teacher in medical school. So I'm happy to learn from him again outside the classroom. Okay, so my question also directs to him. I was wondering, when you present the graph that correlates the shunt procedure and the ETV, that is the endoscopic procedure. So the downward trend that the graph follows, so I don't think you address that. Is it that there are now newer procedure that cause a downward trend at the last part of the graph? So I want you to maybe shed a little light on that. Then the second question, I was wondering, when the patient that gave account of how she did the first CT scan, so that records a normal study, is it that something was missing in the first review, or the pathology was actually not there as of the time the patient did this, and so I want to know what exactly happened. Or perhaps, as the case was negative, whether there is something to build on that. When there is clinical suspicion of a pathology and CT records a negative imaging, whether at that time a superior imaging should be requested as of immediately. So I want the panelists to address that. Thank you very much.
Thank you very much. I think that's all. That's the last. Okay. Please, Professor Bankole.
So I'm actually going to ask Professor Oyesiku, sir, if you don't mind talking about the first question that had to do with helping doctors know the limits, because I think you were trying to address that when you were talking about centers of excellence along those lines. So if you can just go on with that, sir.
So the specific question is, how do doctors know the limits of their capabilities?
Understanding. So my brother, what I'll tell you is that even when you are speaking English to English-speaking people, they don't understand medical terms. Like, the truth of the matter is that at that time, you are not really listening. So again, as physicians, what we must learn to do is you must repeat, and not at the same time. And then also get a feedback from, okay, what do you understand from what we've told you so far? And just understand that they're not going to get everything the first time, or the second time, or the third time. And some of that explanation needs to be an ongoing thing. The other things with language, we'll have to help, the language specialists will have to help the doctors to come and do something about that. To the question on shunts. So when a patient has post-infective hydrocephalus, the infection has cleared or is clearing. You will not put in a shunt until the infection has cleared. Ideally, once there's infection, you must wait for the infection to clear. That's number one. Then what I said is that it's not as if you can't do an ETV or endoscopic procedure with post-infective hydrocephalus. It's just that the success rates are much lower. And if you go in and you find certain things, you must realize that, look, it's not going to work in this case, and convert to a shunt. So that's probably, and so patient selection is key. My slides were too many. That's the problem when you give somebody who talks. I had too many slides, so I couldn't get to the end. But patient selection is important in anything you do. In anything you do, even in as simple as deciding who do I put in a shunt in and who do I treat endoscopically. So there's not an alternative to post-infective hydrocephalus per se. It's just that if you're going to do endoscopic thoracostomy for a post-infective case, you must be very careful with your patient selection. And I think that would also address the question that Dr. Wahab asked. I'm not sure which we're talking about in terms of the numbers. Actually, if you count the total number of cases, we are doing more cases. It's just that the number that we're doing endoscopically had dropped in the last few years. And that's, like I explained, was just the percentage here. That's because we had some scheduling issues and manpower challenges. But hopefully we are getting over that. So I'll allow other people. Andrew, you had a question?
Yeah. To answer the question. Yes, so there was a question for me about in terms of patient selection. How do you decide for patient selection? It's been a few couple of hours, but we've actually spoken about different types of tumors. I spoke about skull-based tumors. Professor Balogun spoke about what I'll call intraaxial tumors, so tumors within the brain themselves. So that's why you do a wake for them. It's totally different. Skull-based tumors are usually benign, but they're from outside and they are squashing the brain or squashing the nerves. Now, how do you decide on treatment? When I speak to patients, I usually most patients know me with my fingers like this. I will tell them that my job is to make you better. This is the one going up. If I can't make you better, then it's better I leave you here. Because there's a third option. We all don't like the third option. And we're not God. As neurosurgeons, we do our best. And sometimes we're incapacitated by the resources available. And sometimes people don't, when the patient advocate was talking about our experience, I was thinking to myself, and when the gentleman spoke about a really close family member who had what we would presume is a brain bleed, I was thinking about the figures where I work. We were talking some months ago about how the numbers have dropped nationally because you're in a system where nobody pays for healthcare. So if you sneeze, you get a scan. We know that 6% of the population have an aneurysm. If there's 100 people here, 6 people will have an aneurysm. So when you're scanned and an aneurysm is picked up, you are treated immediately. The old days, and that's what still obtains here, you're treated when you have a bleed. Because you're not going to just be scanning yourself for how much is a CT scan or CT angio. We're not just going to be paying for a CT angio and say, look at my head, is there an aneurysm? Most Nigerians don't do that. So and these are the little realities that we are not aware of. So sometimes we think our system is worse. It's not worse. It's because healthcare is a grudge payment. When you are told, it's painful. And like Professor Bankole said, you don't even understand what they're talking about, because I can remember when I was a house officer in UCH, when we tell a patient, I need photo of Bolo. Oh my God. I used to feel so bad because I know that I've broken the hearts of many family members. But in other countries, you treat them immediately. So now, when we look at the national numbers, we're not seeing brain bleeds as much as before. They've compared the figures now to figures 10 years ago, and it's different because now they're treated immediately, they're picked up. We always knew that when you have a brain bleed, 1 out of 10 people do not go to hospital. That was what we used to tell everybody. They would not get to hospital because they die before getting to hospital, because it's the way brain bleeds are. But now it's different. But can we afford that? Which is a totally different discussion. It's outside the remit of this, but I just want you to know that so that you have some insight into some of the things that are happening. Thank you.
Thank you very much. Yeah.
Oh yes, so you said something about the CT negative. I say yes, so that's something. So with if there's someone who has a brain bleed and your history was very typical, you would want a very good CT. Now, oh God. So I was talking with a hospital CEO in Abuja, and they were telling me that to get a proper scan, we need to spend billions of naira to get it. But if we get that scan, Nigerian patients cannot afford it, so we would never make a profit. So we'll have to go to maybe some other countries like China, to buy it. And, maybe it might not be clear. So that's one discussion, okay? But if you need if a CT is clear, you need it properly reported by an expert, and we would say a neuroradiologist, who will find a trace of blood. And you need something called a lumbar puncture. So we do something called a lumbar puncture, which again will be some other payments, who's routinely going to want a lumbar puncture here? Do you know what a lumbar puncture is? Stick a needle into your back. And a lumbar puncture is usually positive for about 6 weeks after the initial bleed, even when blood does not show up on a CT. So your CT can look fine, and really the doctor who sees you can send you home because they think your CT is fine. They think it's fine. And if they tell you to wait another 12 hours or another night to pay hospital payment again, a lot of people will say no. That's the truth. So with the brain, it's a very touchy subject. It's very difficult. But yeah, I'll stop there. Thank you.
Thank you very much. The last question is about digital health. He was asking about...
Oh, that was like private consultation. You see?
Please, a round of applause. Yeah.
Everybody at the same time.
Okay, thank you very much. Let's appreciate our panelists. Thank you. Thank you so much. Please, 1 minute. We want to have a group picture with. Oh, they said they should put Prof. It's okay. To Dr. Okafor to continue the next agenda on the yeah, thank you.
Thank you, audience, for a very engaging question and answer session. Thank you, our distinguished speakers and panelists, for giving us for sharing your knowledge with us. We are going to have another testimony from another patient that has benefited from the expertise of our distinguished speakers here. I would like to call Mrs. Ebere Igwe. Are you here, please? Please come up and tell us tell us your story.
Please, let's appreciate her. She comes. Take this away. Please, let's appreciate that one more time.
Thank you so much. Okay. It's actually more intimidating than I thought. Hi everyone. My name is Ebere Igwe, and please forgive me in advance just in case I get a bit emotional. It's not from a place of pain, it's from a place of gratitude, because I am that one that God, my name is Mercy, and He's been very merciful. I could have been talking about losing a child today. This is Chloe. Chloe Kamyechuku. Okay. Chloe means blooming. Kamyechuku means give it to God. And she's 18. I've always only known the Nigerian disease, malaria and typhoid, at least in my generation. But last year, we went through an experience which I choose not to call it challenge. Nathan, please get what is in my handbag, in that little bag, in that little plate. Thank you. I choose not to call it a challenge because it's an experience, and I don't know why I'm honored to stand here today to speak to people. And I want to believe there's someone that this would speak to or minister to, whichever way you say it. So September 2nd, 2025. And okay, we were in another state. I'm not going to mention the name of the state because I'll be giving away some things. So let's keep it a little bit low. Mid-August, I was redeployed to Lagos, and I had to leave towards the end of August. My family would join me. Their dad would join much later. The kids would join me, but I had to leave first. So I had been in Lagos just barely 5 days, and I was called at about 9 a.m. It was a video call. My husband was showing me Chloe, and like, she's not doing good. We need to go to the hospital. And I'm like, okay, have you given her Panadol? You know, those things, those markers that as a mom you would do. Okay, Chloe, what's the pain level? What's the days? Because we have our, should we go to the hospital? That's usually the last one. And if my child says yes, because we don't like hospitals, but if they say yes, then you know it's serious. And then there's a doctor neighbor of ours, an oncologist, and I said, okay, can you check him if he's there? Since she was in so much pain, let's even know if there's something to give first, because I didn't really trust my husband on what he was going to administer. And so they called the doctor, and after giving her a shot of painkiller, he said, we need to take her to the hospital. So we went to his hospital, or they took her to his hospital, and that began our journey. I was calm in the office, continued my day. At about 2-3 p.m., my son, who was 12 at that time, was in the hospital, was updating me. Dad was running up and down until at some point I was told she had gone. And I just called her older sister in the university. We prayed, because I don't know what's not good to do. If she's gone, she's gone. I mean, what could I do? But immediately I knew I had to book a ticket back to that state. And first thing the next morning, I was back home, of course, to the hospital. And my daughter had not opened
walking or standing. That's neurogenic claudication, mechanical instability that generates pain at the back, failure of adequate conservative treatment are also relative indications. With respect to caudal equina syndrome, we're talking about people developing problems controlling urine and feces, plus or minus back pain, plus or minus weakness of the lower limb. And all this talks about having difficulty with perception of sensations in the limbs and sphincter problems and also weakness. So I'll be talking around some of the pathologies that we manage. Lumbar disc herniation, that's pretty common in our environment. And with lumbar disc herniation, it is a disease of the adult and the middle-aged people, really. And it is, it usually presents with back pain, plus or minus radicular pain or weakness. The current gold standard in managing this entity is microscopic lumbar discectomy. This is MRI of one of our patients with disc herniation. I think this patient, yes, this is the patient we operated last week, actually. L45 disc herniation. The canal is really stenosed there. And this is our fluoroscope at surgery where we're doing laminotomy and discectomy for these patients. The other options for managing these patients include the tubular microdiscectomy, endoscopy, and the benefit of this is that these are minimally invasive or minimal access surgeries. It gives less tissue injury, and then smaller incision, unilateral dissection oftentimes. Laminotomies instead of laminectomies, faster mobilization. Our patients started walking the very following day after surgery, and excellent clinical outcomes. The important thing here is that quite a number of people still do, that's people who operate on spine surgery, still do laminectomies for these lesions. The standard practice is minimally invasive surgery. That's one of our surgeries where the disc is being extracted. The spinal cord, this is the spinous processes. The spinal cord has been retracted to the other side to get access to resect the disc. Yeah, so we're talking about laminectomy. Laminectomy is removal of the posterior elements, the lamina, the spinous process, the ligamentum flavum. Those are the structures that are generally removed. It gives a level of instability to the spine, although the spine still generally remains stable, but at least you have reduced the stability of the spine by doing this. If the patient needs it, why not? But for management of these lesions, lumbar disc prolapse, we prefer to do a minimal opening and resect the disc as you have seen in the video. That is biportal microdiscectomy ongoing there. And these are some of the tubes that are used in tubular discectomy. That is intraoperative fluoroscope depicting that same procedure. That's the tube in there landing on the spine, and the instruments will be passed through that portal, as we see there. So, lumbar stenosis. Stenosis simply means that the canal, the spinal canal that contains the cauda equina is narrowed, and all of those neural tissue is being squashed under compression. So we see here that this is the spinal cord, that's CSF. By the time we are getting to this level, we cannot see the CSF anymore. The spinal, the cauda equina is being squashed there. And that is the axial cord with, demonstrating the stenosis. And these stenosis can result from disc prolapse, ligament hypertrophy, listhesis, and also tumors and other lesions there. The goal of management is to decompress while we are preserving stability. Generally, when these compressions are essentially at disc level, the management is usually minimal invasive approaches like I showed earlier on, and not laminectomy that will remove extensive portion of ligaments and posterior elements. So what we need to be focusing on in Nigeria right now is dissemination of the skills in endoscopic spine surgery, which is already available here with us in Lagos, and also in Kano and in Lagoon also. Oh, okay. In Kano and Lagos, and I understand that people have also been going for short fellowship training, which is very good. We need to disseminate the skills so that we treat people appropriately. Just imagine a 35-year-old, you are removing extensive portion of the spine, which is what we have been doing hitherto. Minimally invasive is the way to go. Fellowship training is very crucial. Lumbar fusion techniques are very, very important, because when there is instability, it is important, or when there is instability or impending instability, because at times at surgery, we resect portions of the spine that predispose the spine to instability. Then we have to fuse. So instability, spondylolisthesis, deformity, revision surgeries, we have to be up in our games with respect to revision surgery in Nigeria right now, because we've entered the phase of instrumentation earlier on. Now we are getting patients that require revision of those things that we implanted earlier on. And then some selected mechanical back pain will need fusion surgeries. And the various fusion surgery that we do, generally, this is the most common, posterolateral fusion. In other words, you fuse the spine along the lateral gutters, the transverse processes, you decorticate them, and then you fuse. However, it is much more beneficial, creates a lot more stability when you do interbody fusion. And all of these that we see here are just the various pathways and the various forms of interbody fusion. What we mean by interbody fusion is that you place grafts in between the vertebral body, and remember, you are going to be reaching anteriorly in the spine. Most of our spine work come from behind, okay? And for the posterior lumbar interbody fusion, you're coming from behind, you're doing a laminectomy, retracting the spinal cord, and slotting in cage and graft in between the vertebral body. For the foraminal lumbar interbody fusion, T-leaf, you are going through the neural foramen to do the same. It provides us with less retraction of the spinal cord. The essence of this is that it gives us better fusion and better prognosis. These are some of our patients that we have treated. I don't know how clear this is, but this is a flexion and extension studies that is showing spondylolisthesis L5S1 in this patient with a huge lumbar lordosis. She got a T-leaf. That's what we did for her to manage her spondylolisthesis. Sagittal balance is a major issue in management of lumbar spine diseases, because the general talk about spine surgeons is that you are either treating a deformity or you are creating one, okay? Very important in our terrain here, we need to focus more on the assessment of the sagittal balance of the spine, both global and regional. And these parameters need to be factored more into our decision making. However, the environment is handicapped in the sense that we don't have X-ray facilities that can give us the whole spine at a go. So we are still having to do separate thoracic spine X-ray and lumbosacral spine X-ray, and then join them together to be able to have a view of what the sagittal balance of the patient is. So where to go? We need to have X-ray facilities that can give us the whole of the spine in one film for better assessment, planning of surgery, because when we mismatch these parameters, the outcome, the functional outcome is usually not as good. And that is the next steps that we need to be taking with respect to this. These are all our technical languages, pelvic incidence, pelvic tilt, sacral scope. The pelvic incidence is usually unique to each person, essentially, and it is fixed. It's fixed essentially because of the lumbosacral joint that is also fixed. Minimally invasive spine surgery, again, it's already here in Nigeria, and we need to make it more widespread. This particular surgery, we performed this surgery at King Abdullah Hospital while I was in Saudi Arabia, minimally invasive surgery. This is a compression fracture of these vertebra. Minimal incisions, under fluoroscope, screws passed in, reduction done, rods attached, and patient gets better. Like we said earlier on, the recovery rate is faster for this set of patients, and these are the benefits: reduced blood loss, less tissue damage, earlier mobilization, shorter stay in the hospital. However, learning curve tends to be steep, and then equipment, you need the appropriate instruments to get this done. It's available, but not as much as we will want it to be. And of course, it is radiation intensive intra-op. Endoscopic lumbar spine surgery, like I said earlier on, is already available here in the country. What we need now is dissemination of that skill across board through fellowship trainings of our personnel. It gives advantage of rapid recovery, minimal tissue reduction, destruction, as we have talked about earlier on. Technology. Again, you've heard about the microscope at Lagoon that is the best in West Africa or Africa? West Africa. Great. So the practice of lumbar spine surgery generally is technology driven. Okay, so intraoperative neuromonitoring, 3D navigation, intraoperative CT, these are tools that we need to be able to perform at higher levels. And these are areas where investors can come in really to invest and help improve our practice. So we already have neuromonitoring. We are using them regularly when indicated and affordable. Generally, that's the practice. My last fellowship at Istanbul, we use intraoperative neuromonitoring for every patient, but that's a high-ended private practice, really. Anybody coming there is already a high-ended individual, so they generally pay for it. But availability, affordability. This is neuro navigation. It's out there. There's a vendor out there demonstrating that brought it. As a matter of fact, the machine out there is the one that was used here at UCH. That's me. That's my boss, the Professor A.A. Adeolu, performing neuro navigation spine surgery at UCH. These are tools that will definitely enhance our practice here in the country. Those are the next steps that we need to be doing. We need to be focusing on improving our patient outcomes, enhanced recovery after spine surgery. Gone are the days when you do spine surgery and patient is lying on bed for 2 weeks before moving. No, you can perform big surgeries and they get out of bed same day or following day, and you start mobilizing them early. How do you do that? Patient education, nutrition, optimize their metabolics, intraoperative monitoring, tranexamic acid, adequate analgesia, early ambulation feeding, and infection prevention strategies are also very important. Post-operative spine infection used to be a major issue, but I think getting much less so right now in the country. But these are the various things that we do to reduce it. Glycemic control, very, very crucial. Strict asepsis at surgery, meticulous tissue handling, shortened surgery, operating time. And we use some other things that have not been proven, like putting antibiotics. We don't have randomized controlled evidence for this, but it has been shown to help in various studies here and there. Contemporary challenges in Nigeria, late presentation of patients, essentially not because they don't have the symptoms, but because they don't have the funds to pay for it, and some are actually in denial. Limited access to technology that are required. There is only one MRI scan in Ibadan right now. So some of our patients have to come all the way to Lagos to get their scans done. I know Lagos has multiple spots for it, but affordability might also be an issue. Limited, minimally invasive facilities, navigation, robotics, well, that's costly, but it is doable. And then, of course, out-of-pocket payments, and then inadequate rehabilitation services. Opportunities for advancement includes various forms of training, cadaveric laboratories. When I came back from the US, my thought was, oh, I'm going to collaborate with the pathologists, and I'm going to try my hand on cadavers in their lab, but man, it just fell apart. But in Luth right now, they have a cadaveric lab, I believe. Very good. I think we need to have that across the country, really. Those are the next steps that we need to have. National spine registry. Local implant manufacturing is not far-fetched. Right now, we have vendors all across town giving us implants and instruments. But we can as well look at the possibility of this, how we can get implants manufactured here. You really need to see where those implants are manufactured in India. They are just little shops here and there. You understand? And then you go, you order for your things, and they ship it into the country. It's not so big a factory, as it were. And then, of course, international collaboration, which is already ongoing. Dr. Alalade is here. That's part of it. Future direction, precision spine surgery, endoscopy, motion preserving technologies, and then the technology-driven stuffs that that can help us to do much more than we have done. So, very important that we tilt our practice to be patient-centered and make appropriate patient selection, focus more on minimally invasive techniques. Restoration of sagittal alignment is very crucial in spine surgery. And as Dr. Ojo alluded to earlier on, we are actually making steady progress despite limited resource, as it were. And we need more investment in training, technology, and research. Thank you very much.
Thank you very much, sir. Please, a round of applause once again. Thank you so much, Dr. Laolu Akimbo. We really appreciate that. Oh, so before we call the next speaker, I want us to stretch just for 30 seconds. I want us to stand up, go out, stretch, move around, connect, 30 seconds. Okay. we've
cerebral aneurysms and pretty much just look at an index case. My name is Dr. Uchenna Okafor. I'm a neurointerventionist and neurosurgeon at Westchester Medical Center, and I serve as the CEO of West Africa Stroke Initiative. And this is also an initiative in combination with Lagoon Hospital, where we provide minimal invasive treatment for cerebral aneurysms and whatever gamut of cases we've been able to take care of. And in fact, as we speak, we're here doing treatment for a couple of patients as well. Somebody with a very large left-sided pseudoaneurysm in the neck, left ICA pseudoaneurysm, and we have another case to do. But let's just jump into this very quickly. So looking at aneurysms, we have true aneurysms, we have false aneurysms. And what pretty much differentiates the two is that for true aneurysms, you have a tunica, intima, media, and you have the adventitia. But the media is sort of weak and dilates and gives you this saccular or fusiform appearance. But for false aneurysms, all those layers are degraded and could be quite dangerous as well. Different type of aneurysms, from saccular aneurysms to dissecting fusiform aneurysms to mycotic aneurysms in cases of patients with infection, endocarditis or HIV patients, or trauma, which is quite also common, but you really have to look for it. So patients that have trauma to the head, to the neck, you have to have a high index of suspicion looking for such possible dissecting aneurysms, especially in the vertebral arteries. And then oncotic aneurysms you find in patients with cancer, like atrial myxomas or choriocarcinomas. I'll just quickly move on. So when you have an aneurysm, cerebral aneurysm rupture, it's called a subarachnoid hemorrhage. And these aneurysms have various sizes. And the ISUIA data just gives us an idea of the 5-year cumulative risk of rupture of these unruptured aneurysms. And they range from those that are categorized, less than 7 to 12, 13 to 24, and giant aneurysms, which is pretty much defined as those above 25 millimeters. And then you have the various percentages that we kind of quote for patients of the risk of rupture over that 5-year period. For people that actually rupture, this is just a quick diagram that tells you on day 0, even before they get to the hospital, this is very serious. People that have cerebral aneurysms, almost about 15% of them will die, unfortunately, before they get to the hospital. And as much as 25% mortality overall, even when they arrive. And then for every day without being treated, this risk is cumulative, and then to about day 30, it's almost 30%. It's almost, if you break that down, it's almost 1% per day. And then after that, it drops down to the 2 to 4% per year for patients that still haven't been treated. The Hunt and Hess or the WFNS are clinical criteria for assessing these patients. Now, the aspect we have come to provide in conjunction with our fantastic hospital, Iwosan Lagoon Hospital, is pretty much providing minimally invasive care. And there's this, what pretty much changed the whole, the game was the ISAT trial. The ISAT trial in 2002 pretty much put head-to-head surgical treatment, clipping of aneurysms versus, coiling or minimally invasive angiographic treatment for aneurysms, endovascular coiling, or other treatments that have gone subsequently. And just the punchline is that there's a 7.4% absolute risk reduction. So that means for every 1,000 patients that are treated with ruptured aneurysms, either surgically compared to endovascular, 74 of them will be saved from death and dependency. So that tipped to the favor of endovascular treatment. But guess what? This is over 20 years ago. And I can tell you folks that the kind of devices and treatment options for patients for aneurysms without having to crack open the head, of course, we still occasionally need to do that, so don't get me wrong. There's still a place for that, is so much better in terms of improvement of our devices and so on and so forth. For these patients, many of them, and it's one of them who's going to be our second patient on the list today, is on dual antiplatelet therapy, or the one we're treating right now, actually. So aspirin and plavishib started about a week ago. And the reason is that if we put in devices, These are thrombogenic, and to reduce the risk of causing blood clots and further thromboembolic complications during the procedure, we would give them blood thinners. We heparinize during the case. We do therapeutic heparin. Everything is heparinized as we work through. We're very meticulous about it. And then, of course, despite that, there still could be thromboembolic risk, and we have ways of managing that. This is outside the scope of the study, so this topic, so I'll skip that. What ways can we treat? We can do coiling, which is what most of us probably have heard, where we use our microcatheters, very small. We go through the femoral artery, or we go through the radial artery, and we're able to snake up our guide catheter, intermediate catheter, microcatheters, and we send our coiling catheters to go do the job, or we coil the aneurysm. Sometimes the aneurysm, depending on the morphology, the neck of it is quite wide, so we have to think of other innovative ways to deal with it, to prevent those coils from dropping into the parent vessel. So what we do, we could use balloon remodeling techniques and balloon assist coiling, or we can do stent assist coiling as well. And then the latest kid on the block, apart from intrasaccular devices, is the pipeline, where you don't even need to go into the aneurysm at all. You just lay a stent across the neck of the aneurysm. It shuts down flow, it slows it down, and then remodels the neck, and completely the aneurysm goes away. This is something that was done in the past using Onyx 500 HD. We don't often do that anymore. It's fallen out of favor, where you put a balloon across, you put a microcatheter in, and you feel it, see here, with Onyx. And then once it solidifies, you then pull out the balloon. But it was frothed with a lot of morbidity. You can see almost 7 to 8%. So that's kind of fallen out of favor, using liquid embolics to treat aneurysms, cerebral aneurysms. So you have the standard coiling. You have, there are issues, of course, we're very careful, even doing that, stent-assisted coiling, balloon-assisted coiling. We make sure you anticoagulate during the case as well. But for those who have ruptured, we tend to favor just primary coiling, because the problem is if you have a subarachnoid hemorrhage and the patient has an aneurysm, if you can imagine putting stents and flow diverters and then starting them on aspirin and Plavix. That's just a nightmare, especially for our neurosurgeons in the crowd. That's like a no-no. So usually more favored for unruptured aneurysms, but there are cases where you can what we call you come in, you coil, you protect the dome of the aneurysm, and then in a couple of weeks later, or a month or two, you can come and then flow divert them, at which time the risk of hemorrhage is much less at that point. All right, so moving on, if my slides will continue to move, give me a second. Can you still hear me by any chance? This is stuck, right?
Yes, sir, we can still hear you.
We can hear, okay. So I'm just trying to advance the slide. Give me a live slide showing. Hold on. I will stop sharing for just one moment, and then I'll reshare. Maybe that will help us move this along quickly. I'll share one more time. Okay. Tell me when you can see the slides.
We can see the slides.
You can see the slides. Okay, thank you.
It hasn't moved yet.
Hasn't moved, okay. Oh, okay, fine. Oh, that's moving now. Thank you. All right, so pretty much in summary, as I just take you to the index case and we'll wrap it up. So one thing that is important that makes aneurysm treatments easier, right now we just have a monoplane machine. The ideal, the gold standard is biplane. We don't have available, we're hoping very soon we're able to acquire that. But until then, we are, 3D rotational angiography is very important because that makes life a lot easier. Instead of having to rotate the fluoroscopy machine back and forth multiple times, we're able to use the 3D, get the right angles, and immediately get, good working angles to do the treatments. Anyway, so we want to say that there is definite benefit from minimally invasive treatment of aneurysms. I'll give you the various things we do. ISAT-proved coiling yields better clinical outcomes, 7.4% absolute risk reduction compared to open surgery for ruptured aneurysms. And, it says the future relies on balancing optimal device mechanics, stent coils with precise pharmacological control. So pretty much the West African Stroke Initiative we're partnership with Lagoon Hospital to provide this very needed care to our patients here in Nigeria and hopefully, all of West Africa. We even have one of our fellows who's Dr. Teddy, who's pretty much joined us from Ghana, who we're hoping we also spread things all over to that country. But anyway, this was our index case, and this was where I'm going to wrap up. This lady, in conjunction with Professor Bankole, of course, with Luth, this was the very first patient he had referred to our team. This is a 45-year-old woman, subarachnoid hemorrhage. She had initial, she had a subarachnoid hemorrhage, and then the CT had shown a left pica aneurysm, and then the right side, there was another aneurysm, and guess, believe it or not, people that have one aneurysm look for a second or a third, because sometimes risk factors predispose them to it, either genetics or hypertension or whatever the case may be. Now, this patient also had a right superior hypophyseal artery aneurysm on the right side, so unruptured, because all the blood was sitting in the posterior fossa in the region of the left pica. Posterior inferior cerebral artery, for those who are wondering what that means. So we fortunately we were able to get, and that's the beauty flew down with Professor Bankole's team. Professor Bankole single-handedly went to the head. They clipped the aneurysm very carefully. I wasn't there, it was Professor Bankole and Professor Tuma, so just following on the slide. Initial craniotomy and clipping. He did lateral approach, and then they clipped the aneurysm. Professor Bankole clipped the aneurysm with Tumula, and she did very well. Discharge, went home. So we then came back, did a DSA, confirmed it, that the pica aneurysm was no longer filling. So good, those were good results. And then we then proceeded to do a diagnostic angiogram, and then went ahead to pipeline do a flow diversion for her right superior facile artery aneurysm. So a few pictures. This is the left, a lateral, left vestibral artery lateral view angiogram showing the pica aneurysm. That's it right there. I use my arrow if you can see it right there. Just from the takeoff of the pica, you can see that. So that one was clipped. And then this one shows you the right-sided superior hypophyseal artery aneurysm. See the way it's kind of low in terms of, you see this is the posterior genu, anterior genu, becomes supraclarined, and then that's the aneurysm right there. So that's the one that we flow diverted. This is still showing you the pica. Okay, then we then went ahead, I'll see if you can see this video. I'll just play it now. So this is your right ICA injection, selective injection, and you can see that aneurysm filling ever so, that's the aneurysm. I think it measured about 8 by, I think 8 millimeters or so, 8 to 9 millimeters in diameter. And then we also proceeded to, this is our, some of the trips we've made of our team members. This is Henrik. And this is Chizoba, one of our neurointerventionists in the US. So both from the US. This is myself. This is Professor Bankole. This is Misha. She's taking some of our ground rounds, of course, Dr. Okbara, and lots of the team in Lagoon Hospital. And of course, the techs, everybody here, very fantastic. Dr. Kuyiro has made this very wonderful for us, a wonderful experience. And then a few more pictures as we wrap this up. This is also a right ICA AP injection of the same aneurysm that we pipelined. This was during treatment. Just show you the next one. And then this is just showing that the aneurysm that was clipped was completely gone. You don't see the aneurysm anymore. We went ahead and flow diverted the aneurysm. And then this is now her DSA, where this is post-treatment. We came back and did the follow-up angiogram to make sure that the aneurysm is completely gone. And at this point, you can see completely disappeared. And so we kept her on DAP therapy, which is dual antibiotic therapy, for a period of 6 months. She was a little longer because we took a while to set this up to come back. But generally 6 months is enough. Once you have an angiographic cure, you can see no more aneurysms anymore. She's completely free. Pica taken care of, clipped successfully. The right ICA supraclarinal aneurysm completely gone as well. And these are just still pictures showing the right ICA injection no mannerism. Oh, no, this is a lateral view, and this is, of course, your left vertebral artery lateral angiogram injection as well, which shows no aneurysm. So both aneurysms taken care of, and this is our wonderful team without which we can't, we couldn't be successful. I also have my colleague, Dr. Dan Kaur, who's here. He's actually operating while I stepped out, and we're all working together to try and make sure that this care is available to everyone locally here in Nigeria and beyond. So thank you very much for inviting me. We're very grateful. And thank you to the organizing committee. You've done a great job. Thank you.
Thank you so much, Dr. Uchenna Okafor. Thank you so much, sir. Thank you. We really appreciate the sacrifice. Thank you so much. We really appreciate it. Can you hear us? We really appreciate that. Okay, so
thank you so much.
Everything off. Right now, we are going to be taking the vote of thanks, awards, and photographs. Then, of course, we have our lunch or lunch dinner. Okay, so yeah, please welcome Dr. Motayo Ojo as he gives the vote of thanks. Please, let's welcome him. We have seen his face multiple times, called his name multiple times. It's a privilege to be among the brightest minds, isn't it? Thank you so much, sir.
I think without doubt, we've had a pleasant afternoon/evening. The lectures have been didactic, tailored towards the neurosurgeons, with some aspects that I think would benefit everybody, especially the fact that we need centers of excellence. We need to make appropriate diagnosis and appropriate and timely treatment. To the faculty that have been able to share from their wealth of experience, we say a very big thank you for coming, some all the way from Ibadan, some from England, and others spoke from US. We're very grateful. Thank you to you. To the patients or clients that have been kind enough to share their testimony, which in a way shows what is available locally. You know, when things go wrong, everybody would know. Bad news will travel, oh, they killed somebody. But when we have good results, unfortunately, I can't tell anybody. I just have to keep quiet. It's only patients that can say. And I think we benefited from the perspective of the patient, which is helpful for us to know what to do to make things better. To everybody that had sat patiently to listen, without you being here, we would just have been speaking to ourselves. So we say a very big thank you. Of course, we have to say a very, very big thank you to Lagoon, Iwosan, and management for putting this together. However you look at it, you have gained something. We also will say a very big thank you to the multimedia that somebody had very well called DJ, that I wonder, but anyway, we know multimedia. We quite appreciate your expertise in making everything look seamless. I know many of them came very early and they're still here. Thank you. And I'm also sure that there are some other people we have not seen, but they are somewhere in the background pulling the strings, maybe outside, maybe downstairs, wherever you are. Your contribution has made this event very successful. Thank you. Thank you very much, everybody.
Thank you, sir. Thank you very much, sir. Awesome. I'm actually, I've been fed to stupor. about neurosurgery cases. Thank you so much. We thank God for everything. Right about now, we want to present awards to our distinguished neurosurgeons. We just want to appreciate them from Iwosan Lagoon Hospitals for their time, their sacrifice, I mean, for everything they did for us right now. They did it free. I mean, we all came in free, nobody paid a dime. So, and we have learned so much. So just want to say thank you, just a token to say thank you to everything that they have done. So in no particular order, you just be calling their names one by one. And we want our MDs to do us the honor of presenting these awards to them. So right now, I'm going to call up our MD CEO, Iwosan Lagoon Hospital, Dr. Oyeniran, to please come and present awards to, please, the first person, in no particular order, please.
Dr. Olaolusi Akimbo. Yes, those two are not, they are not here. So Professor Femi Bankole. Dr. Hamid Ninolo. Professor James A. Balogun. Dr. Omotayo Ojo. The last but not the least, Dr. Andrew F. Alalade.
Thank you very much, sir. Yeah, thank you. Thank you, everyone. So right now is photograph and going for our launch. So we want it to be in an orderly manner. So we want the consultants from here, consultants, the MDs to go first. Just relax, okay, and we go afterwards. So we go with this row first, followed by the middle row, and of course, this is not the last, but you go this way. So our consultant MDs can go and have their lunch. But while we are doing that, we are going to be taking pictures with the neurosurgeon. So do we understand? So we are going for lunch now, but before that, we are going to be taking pictures. So while we are taking our pictures, we can go for our lunch. So MDs, MD, before you go, please, before you go, we are going to take picture neurosurgeons and MDs. So all the MDs and neurosurgeons, please come in as in presenters, speakers, please. Not all neuros. I know we have other neurosurgeons. I mean the speakers, MDs and speakers, please. So while they are taking that pictures, if you are all the neurosurgeons or all the consultants in our midst, all consultants, radiologists, neurologists, any consultants, radiation oncologists, family physician, all the consultants, you're going to be taking picture with the neurosurgeons too. So if you are here, please, all the consultants, once they are done, once the MD is down, please, our neurosurgeons are going to take picture with almost everybody, I beg. Please just stay. All the consultants in our midst, please, we want you to come up right now. I beg, we beseech you, just come, all consultants in our midst, all consultants. Please, stand up. I want me to call your name. I know you. Come. Please, all the consultants, come up right now. And after that, Lagoon staff be getting ready to snap pictures with our neurosurgeons. Then everybody. The students too will join. Everybody, yeah. So all the Chief, I see you there. Where are you? Come up now. All the consultants. After that, all Lagoon staff, we are going to be taking picture with the neurosurgeons. All Lagoon staff, we are going to be taking picture with the neurosurgeon. And after that, then medical students, everybody, we are still all going to join the neurosurgeons. Please, I'm also a consultant. Thank you very much. Thank you, sirs. Lagoon staff, please. Lagoon staff, exclusive is the old, don't worry. Iwosan, yes, we all stay here. Then afterwards, everybody. 2026 Neurosurgery Symposium.
Thank you, everyone. Please, we're starting the buffet, so we'll just show you row by row. You go out and get your food, please. So if you can just stay seated, and the ushers will.
Iwosan Lagoon Hospital staff. Hello. You want us to step forward? You can come forward. Don't worry, they will see my head. So, sir, we want all the neurosurgeons to sit down. Please, sorry. We want all the neurosurgeons to sit so that we can be, because we are still going to call in all the... Good. Please sit. It remains one more. One more. Yeah. Don't worry, I can come and sit down. Don't worry, I will sit. It's a privilege, sir.